and Ron will be here in about now.
Well, please do.
You don't have the juice. This committee doesn't have the juice.
Legislative committees are starting.
Sure.
Okay, and then is Dr. Klein joining us today?
I don't know. I have not heard.
Okay.
We know Levon Lewis is not.
Okay.
And Terry Johnson, Lynn. Oh, and here comes Dr. Klein. So I think everyone's here who's coming.
All right. Well, then this is the posted time and place for the Silver State Health Insurance Exchange meeting. We're teleconferencing here between Carson City and Las Vegas. And with that, I am going to ask Mr. Hager to do the roll call for us.
That's why we have this, so we can see where it's going.
Dr. Johnson?
Yep. Yes.
Director Molenkamp? Here. Director Wilden? Here. Dr. Ford,
Here.
Dr. Klein,
Here.
Ms. Edkins,
Here.
Ms. Lewis has indicated she'll be absent, Ms. Kerr,
Here.
Ms. Johnstone,
Here.
and Chair Campbell.
Here.
Quorum.
All right, thank you, Mr. Hager. We also have present with us here Keith Marcher from the Attorney General's office, who will be assisting us today. So welcome, Mr. Marcher. We will open the meeting with public comment. Do we have anyone here in Carson City that would like to take advantage of public comment? And I believe Terry Johnson just walked in Las Vegas, so welcome, Terry.
Thank you. Good afternoon.
Thank you. Is there anyone in Las Vegas that would like to take advantage of public comment?
Yes.
Thank you. If you would please identify yourself for the record.
Good morning, committee members. For the record, I am Jan Crandy. I'm a member of the Nevada Commission on Autism Spectrum Disorders. In March, I was selected by the HHS Secretary Kathleen Sibilis to serve on the Interagency Autism Coordinating Committee. I also helped pass the autism insurance mandate in Nevada and currently work for the Autism Treatment Assistance Program in Nevada. Autism is a special population you are considering. I'm here today to ask you to be a part of that hope that changes lives. It is not just about doing the right thing for each child, but the impact of what you decide will affect the physical health of Nevada. The CDC last month released new data which indicates autism now affects 1 in 88 children. With those numbers, it is critical that Nevada include evidence-based treatment, applied behavior analysis for autism in the essential health package benefits. In making coverage decisions under mental health and substance abuse services, including behavioral health treatment, this group must consider congressional intent to cover behavioral health treatment for autism. 90% of the children with autism who do not receive treatment will need some type of lifelong support. They will be dependent on taxpayers in Nevada. Treating autism now will save Nevada money. Our goal has to be to help each child reach their highest level of functioning so Nevada can save dollars in adult care and special education. The price tag to provide a lifetime of care for one untreated low-functioning person with autism can run as high as $6 million. Current out-of-state placement costs are at least $500 per day. Nevada Medicaid is and has paid up to $15,000 a month for out-of-state residential placements for individuals with autism. The actuary cost study done for Nevada in March of 2009 estimated the annual mandate claim cost per covered person and premium increase as a percentage of the premium would be less than 1%, or an annual premium increase of $22.90. Research has proven 47% of the children with autism who receive evidence-based treatment, ABA, can reach normal functioning levels, demonstrate an increase in IQ points, and attend regular education classes, become independent adults. I am lucky because my daughter was fortunate to receive these intense levels of treatment, 35 hours a week until she was 6 years old. She is in that 47%. She will graduate this year with a 3.2 GPA. Her IQ was in the 70 range, below 70. Today, it's 104. She will enter the job market and start community college in the fall. She will be an independent adult. Including treatment for autism in the essential health benefits package will result in a decrease in the level of supports in adult care, and for some, an independent life like my daughter. I have brought a copy of the actuary cost estimate done by Oliver Weinman and an overview done by Autism Speaks. We are grateful that Nevada legislators study the research and the cost and chose to pass the insurance mandate for autism. I hope and I ask this committee to support their decision and include it now. Nevada cannot afford to take care of the untreated children when they become adults. Thank you for your time.
Thank you very much. And if you have something there that you wanted to leave with us, would you please give that to Dr. Ford? Thank you very much. We've called our meeting a little bit earlier today. Normally we meet at 1:30, but we've called our meeting earlier today because we've had the opportunity to have individuals from the United States Department of Health and Human Services here to talk to us about what's happening in ACA on a state-by-state level and also a federal level. So what I'd like to do is welcome Herb Schultz here, who is the Regional Director of Region 9 for HHS. And Herb, if you wouldn't mind just introducing the rest of the staff that you brought with you today.
Good to push it. Good afternoon. It's a pleasure to be here with you. I should point out in the audience is Stephen Weiner from my office, who is our regional outreach and policy specialist, and he has day-to-day responsibility over Nevada, which I'll talk about in a second what that means. And whereas Brandon is here, Brandon Smith from the Centers for Medicare and Medicaid Services, who is the project lead on the exchange. So he's really the day-to-day operations lead that works with the board, with the executive director and the staff at the exchange to do that. With me is my colleague, Teresa Miller. Teresa was recently appointed as senior advisor to Steve Larson. Steve Larson is the executive director, or I should say the director, of the Center for Consumer Information and Insurance Oversight. So CCIO, Center for Consumer Information and Insurance Oversight, the entity within CMS that is responsible on a day-to-day basis for the oversight of much of the implementation of the Affordable Care Act, the private market side of it, not the Medicaid side, which is another center within CMS. And so Teresa's here as part of a cross-country tour working with the regional directors to really come out. Our goal today is really to sort of hear and to listen. We're going to be here for a couple of hours. Just wanted to sort of make a couple of comments, and I will give out my email, my cell phone. As the regional director, my role, I'm a presidential appointee. I serve as the senior representative to Secretary Kathleen Sebelius in Region 9, Nevada, California, Arizona, Hawaii, and the Pacific. And I've probably been in Nevada probably more than 36 times in the 2 years, in this area a lot, and I want to thank many of you that I've sort of met in the past, but want to make sure that we came today to say that we're really here at a very historic time and want to be as supportive and as helpful to the exchange, to the state, to various stakeholder communities, to the governor, and to others as you go about your work in implementing this law. And so my office really serves as, if you will, the bridge to the community, whether that be the governor, legislators, local officials, as well as working with consumers and providers and health plans and businesses, small, medium, and large, agents, brokers, academics, philanthropic organizations, sort of the whole panoply. And so Teresa and I are here. Teresa's the senior policy advisor, as I said, to the director of CCIO, is really to be as helpful as we can to you. There may be questions that board members will have. We certainly want to engage not only with the board and with the staff, but with stakeholders. I'll give you that information. And we'll be here for a couple of hours. And so certainly if the board has questions, certainly if anyone in the audience has questions, we're here. We can certainly take comments as well. But between HHS, me representing the secretary, and Teresa representing CMS, our work is there to ensure not only sort of that we provide the education, which I think is good if there's sort of questions, but we're very clear in this administration, from the White House, from the president, and from the secretary, that the important thing about this law, and I think all our laws, but specifically I'll speak about the implementation of the Affordable Care Act, is that we need, want, desire the ongoing input and feedback of all of our communities, both government and non-governmental external stakeholders, to ensure that the implementation of this law is done as effectively as possible. So obviously the exchange, our public comment this morning, the point around the essential health benefits and the work that's being done there, very important short-term and near-term decisions that have to be made in order to ensure that the people of Nevada are able to enroll in a robust exchange. And so we're really here to sort of hear and observe, but happy to answer any questions as well. If I can have 2 seconds, I'll give out that sort of information so that people have it. But Stephen and I, separately and together, are in Nevada quite frequently. I'm actually not leaving the state. I'm heading to Reno to take a flight to Las Vegas tonight to do a forum for the community on grants, and it's not just limited to HHS, but what grants and opportunities are available. But at its crux, my office really serves as the entry point so that you don't have to sort of look every day to 3,000 miles away. Brandon's there as well, Stephen, but from a policy perspective, when there are issues, when there are questions, when there's the ability to engage the community and educate the community, invite us. You know, we're a short hop away. We're based in San Francisco, and it's a short flight no matter where we are in the state. So it's for the audience and for the members, that you'll have that. And I have cards if people wanted the cell phones on there too. It's Herb, Herb .Schultz, SCHULTZ, at hhs.gov. As I said a little while in the legislature, not a Herbert, so it won't get to me with all of the security systems we have in place. So Herb, Herb.Schultz, SCHULTZ. Cell phone, which is best for those that are tech savvy, it texts, and if you want to sort of, you know, just call and say, we want you to call us back, that's fine too. 415-265-7049. That's 415-265-7049. Our goal is just to, 1, be transparent, and 2, to really observe and to ensure that we can be as helpful as possible at this time as you go about your work. And so congratulations to all of you. We know it's been a very, very quick start, and appreciate the work that the community's been doing, as well as the board. You know, we followed the legislation. We don't take positions on state bills, but we followed it and have been really actively engaged in working with John and now Sharon and others to do it, to be there for you.
Thank you, Herb. Before we get started, because this group of rooms is different for us, so let me just, we want a lot of dialogue in the next hour or so that we can ask questions of Herb and of Teresa, and obviously we'd like Stephen and Brandon to jump in if they have anything. How do we get microphones to individuals out in the audience here?
There's wireless microphones.
We've got wireless, okay. And then down in Las Vegas, I can see we've got public coming to the table to ask questions in that. So is there enough coverage there for people to ask questions that they can get to microphones, Dr. Ford?
Yes.
Okay, thank you. And then, all right, so will you help us with the mic if we, okay. What I'd like to do is open it up for discussion, probably first with our board members, if they have any questions. Herb and Teresa and Stephen and Brandon met in the governor's office this morning and spent about an hour and a half there with Ann Wilkinson. And from there it went over to the Legislative Council Bureau and had a meeting with some of the legislators there. And it was amazing to me that in both of those hour-long dialogues, we really didn't have a crossover of questions. So I expect that we'll have different questions here today as well. But what I would like to do, if we have someone on the board, voting members and non-voting members, if you would like to get started with some questions with Herb and Teresa or anyone here, I'd open it up for conversation and questions and answers. Does anybody want to get started down in Las Vegas?
And I just say, certainly we're here, that if there's not at this point, we're going to stay for a couple of hours, and so as you go through your dialogue, we're happy to answer questions at that point if things come up.
Why don't I ask the one question that did cross over both, because you do have an answer for that, and I think the answer is a not answer, I think. But one of the questions that came up both in the governor's office and at the legislature is, with the pending Supreme Court case and not having a ruling on that case at this point in time, how are you handling things on a go-forward basis?
Well, I appreciate the question. We are, as an administration, we are very confident that this law is going to be upheld. And so what we spend our days doing, not just in HHS, but in all the government departments that have responsibilities to help implement this law with the American people, is really work every day to not only outreach and education, but to ensure that the benefits and the services that are being provided. A lot of folks think that the Affordable Care Act begins January 1, 2014. It's just with any big law, it takes time to sort of get a general level of knowledge up there. But there are significant parts of this law that have already gone into effect. Things like, for seniors and people with disabilities with high prescription drug costs, billions of dollars have been saved, an average of $600 per senior, if you will. I think in Nevada, it's about an average of, if I remember right, $538. About $12 million have been saved by seniors and people with disabilities. 18 to 26-year-olds getting access to coverage through their parents' plan. The pre-existing condition insurance plan for uninsured Nevadans who have been uninsured for 6 months. And so every day our work is very focused squarely on ensuring that we're working with the communities and we're implementing that law. There's not a contingency plan. We're very confident that the law will be upheld.
Mike Weldon?
Thank you, Madam Chair. Herb, I think it might be beneficial for the audience today. We talked some length this morning about tight time frames. And I know there's been discussion before about, is there a possibility of waivers or extensions or that type of business. So I just think it's important for people to hear that. I believe I heard it loud and clear today that was a 2-letter answer, N and O. And so, again, there's lots of pressure, so maybe some comment there.
Thanks for that question. It's a great question. And again, my name's Teresa Miller. So as we talked about this morning, I think when you look at the guidance and the decisions and the regulations that we've put out over the last few years, really, there's really one common theme throughout, and that is state flexibility. And we've tried to do everything we can to encourage states to put together and establish their exchanges and do everything we can to support that. So we have relaxed some deadlines. We have extended the ability for states to get federal funding to help develop exchanges. And but at the end of the day, what the message we delivered this morning and the message we're trying to make sure gets out there is the deadlines in the statute in terms of the January 2013 deadline for states to be certified by HHS in terms of their exchange, and the January 2014 deadline for exchanges to be up and running. Those are statutory deadlines, and they're not deadlines that we have the ability to extend. So as much as we're trying to offer flexibility and we want to do everything we can to support states in establishing their exchanges, those deadlines are real. And so we're here to help in whatever way we can, but in terms of offering some sort of extension in terms of those deadlines, we're not able to do that.
I'm going to toss it back down to Las Vegas. Any questions there? All right, how about back up here? Mike, Marie, did you have a question or comment?
I hope this isn't somewhat redundant. Some of us have run businesses, and we always have to have a plan B. The what if, that then I'm going to go down this route. Now, we understand what the federal government is doing. In terms of the states, I'm sure that some of our exchange officers are probably curious about this one too. Where will the state exchanges be if the United States Supreme Court says no? this isn't happening?
Well, I'll match you. At the risk of being redundant, I'll be redundant. When I say we're focused every day on ensuring that we're helping to educate together the American people and provide the services and make the decisions that need to get made, that really is what we're doing. So we're not going to conjecture because there isn't a contingency.
We have a public question from Las Vegas.
Thank you.
My name is Peggy May Johnson, and I'm executive director.
I'm sorry, we can't hear you.
Hold on.
Okay.
And-
I have such a loud voice that it would reject.
And then, if you'll stop just for a second, please. We're getting a lot of feedback if more than one mic is turned on. So if everyone can make sure their mic's turned off and the speaker then could identify themselves for the record, please. Thank you.
Barbara, we were told we only have one mic and we're passing it around.
Okay, thank you.
Is it on when it's red?
On now.
Okay. My name is Peggy Mays Johnson. I'm executive director of the Consumer Assistance and Resource Enterprise, also known as CARE. And people have asked me as I've gone around speaking to them about the Supreme Court decisions when it comes down, if the whole act is stopped, is there an opportunity for this state, having chosen to be an exchange, could we in fact move into, since we're already getting ready, into the same kind of a program that Massachusetts has?
For the record, John Hager, Executive Director. What I will say is that the legislative intent provided by Senate Bill 440 is that the state of Nevada set up an exchange with or without the federal act. There are several references in the statute that indicates that if the act were repealed or held unconstitutional, that we would have to further define certain items in regulations. So from a legal matter, we are set up, our mission is to create an exchange in Nevada. From a practical matter, if the funding stops, we'll have to figure out where we're going to get the funding to actually pay staff and consultants and implement. So there are two sides to that, and if the act is in fact repealed, we will have to find another source of funding, basically a loan from somebody, whether it's the general fund or we go out as a nonprofit and start that way. But that will certainly be an issue for Nevada.
Do we have anyone here in Carson City that would like to ask some questions or comments? Okay, how about back in Las Vegas again?
Hi, Angela Ibarra from UMC Medical Center. I just wanted to ask her, if you're coming to Las Vegas tomorrow, where are you going to be and where are you going to be speaking at?
I will look on here as to where the address is, that I will tell you. But the Moonridge Group, in coordination with Senator Reed's office, is having my colleague's bringing the address, is having a federal funders forum. And so I'm going to be addressing the Affordable Care Act and some of the overall grant opportunities. So it's going to be at the Clark County Library, 1401 East Flamingo Road in Las Vegas. And registration starts at 7:30 and it will begin at 8 o'clock. And there will be, I think, around 10 to 12 federal agencies that will have tables set up so that the community can come in and talk about potential, sort of grant opportunities or services that, our agencies provide. For example, as you know, we run the Temporary Assistance for Needy Families program. We run the Head Start program. And so an opportunity to, help the community know what services and grants are available from all these government agencies.
Thank you.
And if you'd like a copy of the agenda, if you just send me I gave my email out at herb.schultz@hhs.gov. I'm sure we can send you the flyer.
Record Barry Gold with AAR. That is a limited space event, and Senator Reed's office is asking that you RSVP through his office, through Senator Reed's office.
Thank you. Anybody else down in Las Vegas?
Is there a reason why we're just now hearing this? Was it publicly announced?
Actually, the event that Herb is talking about is not a Silver State Health Insurance Exchange function or event. It sounds like, in fact, Herb might tell us a little bit more who's sponsoring it.
Yeah, they're a group of community leaders in coordination with Senator Reed. I know have been doing a lot of work over the last month or so in trying to get the word out about this event. But yes, it's not affiliated with the Silver State Exchange. It was an indication on my part that I actually was continuing to be in Nevada and actually am flying back on Sunday morning on a 6 a.m. to participate and speak at the AIDS Walk in Las Vegas as well. So. These are other activities as a part of my being regional director and wanting to work with Nevada.
And this is Lynn Atkins down in Las Vegas. I believe that event was directed at nonprofits primarily, and that's who it was marketed to, so it is not part of this organization.
Anyone else here in Carson City? I'm going to kind of try and throw this back and forth. Las Vegas?
Hi, I'm Ann Gasway with America's Health Insurance Plans. This question is kind of for John and Teresa. Nevada's already received its level 1 establishment grant for the establishment of the Silver State Health Exchange. Would that funding be impacted by the lawsuit? Or I think, Herb, you've said in before when you and I have spoken that the money's already in the bank, so to speak. So would that funding still be available for the work that's underway now, regardless of the outcome, or would that funding be impacted?
I'm just going to say again, and hello, Leanne, how are you? I'm just going to say again, there is no contingency plan. We are not looking at the issues around what if this, what if that. We are confident that the law is going to be upheld.
And John, you might go into a little bit more detail where we are in the process of the funding, because we have now applied for our 3rd grant, isn't that correct?
And I could do that now, or I could wait till the executive officer's report. It's up to you. Now? Okay. So Nevada has received a notice of award for, first of all, the planning grant about 2 years ago for $1 million. Our first level 1 establishment grant for approximately $4 million, and that was maybe 6 months or 9 months ago. And then this past February, we received a notice of award for an additional $15 million. Most of that, or all of that $15 million was to go to the implementation and design of the eligibility engine in welfare to support not only the exchange functions, but the enrollment in Medicaid. We have also submitted a 3rd level 1 establishment grant that was submitted on March 29th. That was for another $4 million. That will get us through an additional year. We expect the notice of award to be approximately middle of May, so that would last us theoretically until the middle of May of 2013. So pretty much get us through fiscal year 13. And that would include consulting services for a variety of functions, and we'll go through that in the grant discussion. Agenda item number 7, Mr. Roos will go through that process. But consulting services, salaries, equipment, computers, we're staffing up, so we need couple extra computers for new staff, and we need a place to sit them in the office. We'll have to move out of our current location to a larger facility probably sometime this summer. So a lot of different expenses there. We also plan on submitting our level 2 establishment grant on or about June 28th, June 29th, somewhere in there. That would theoretically get us through December of 2014. It wouldn't provide all of our funding, but it would provide a big chunk of the funding, certainly as far as the design and development implementation of the exchange functions. By that point, we should have our business operations solution vendor selected and know those costs. We will know the costs of the eligibility engine fairly soon, so we'll be able to do kind of a final, this is what we think we need. Keeping in mind that we're still implementing this process. It's hard to see around the bend. We're still getting regulations promulgated every month or so, or every couple of weeks, and so that always changes things, and so there's always the possibility that we'll have to go back for an additional request. But the intent is that the level 2 establishment grant that we submit in June should be the final in quotes request that we hope to have a good solid plan at that point. And I think the work that the subcommittees and the board is doing has gotten us quite a ways. In fact, far enough along that we could actually, I felt comfortable canceling the subcommittee meetings on Monday and Tuesday of next week, letting us catch up with some of the information requests. We're getting some requests to actuaries and consultants to get a better idea of what's going on, better idea of where we should go. So we're on track. We are at a place where I think we'll be able to request those grants. While the notice of awards are not certain, we feel fairly confident that we are in a good enough place that we should be able to get those notices and win those awards when we need them.
Go ahead.
Is there someone there with a question?
This is Lynn Atkins. So is there any, and I guess this is directed at Herb, is there any thought process about additional funding being available after 2014?
I think like any law, we're working on, the decisions that need to be made in 2012 and, 2013. There's various parts of the law that say where the money's appropriated. And there are large parts of the law where those dollars are sort of laid out. And there are other parts where Congress has an additional role to then look at those programs and do that. But there's a whole set of things that has been appropriated, and that's what we're working on now, including, as you know, that the executive director just discussed the establishment grant process. And so we have been trying to be extraordinarily flexible, and as Teresa mentioned, those grants were due to end June of 2012 and now go all the way through 2014.
This is Mike Wilden. I might just comment to Lynn's question. There are dollars that go beyond 14, not so much on the exchange side, but the Medicaid expansion.
Absolutely.
So there's the 100% financing for the new eligibles and the provider rate reimbursement funding, and there's other funding streams, but not for the exchange after 20.
Yeah, correct. And I should have delved down into it, but my broad comment was about that there are things that are in there. The expansion population, just as an FYI, because I think, Mike, you raise a great point, is paid for 100% by the federal government for the first 3 years, and then it transitions over a number of years to 90%. So it becomes a permanent federal match of 10% for the state, 90% for the federal government for those newly expanded dollars for delivery system reform. They're all in there.
Earlier this morning, part of the discussion dealt with the time frame and how tight it was, and not being able to get enough information quickly enough for everyone to respond. I can't remember who asked the question, maybe it was you, John, in concern with the insurance companies being able to put together the appropriate programs to be part of the exchange. Given federal government needs to act first before we can act, and I didn't know if there were any insurance companies that wanted to ask questions about that time frame or get into a discussion with us about how much lead time you need in order to put programs together to be part of the exchange. Doesn't look like it's a concern. Hey, so take your time.
Well, I mean, I guess what I would just say is we recognize, we talk to insurance companies all the time, and we talk to associations that represent insurance companies all the time, and we know how important it is to get these regulations out, particularly around essential health benefits now. I know that's a big issue, and we're working very hard to get those out so that states have that information and can move forward. So we certainly appreciate that lead time is absolutely critical, and we're doing the best we can to get as much guidance out as possible.
Any questions on Las Vegas?
Barbara?
Yes.
Dwight Mazzoni, your favorite guy. I realize what Mr. Schultz has said 3, 4, maybe 5 times, there's no contingency on the part of the federal government. I can understand that. They would have no obligation if the bill is struck down. However, what would we do as a state? We better have a contingency just in case, a backup plan. If not, that would not be very good planning on our part, and we represent the taxpayers of the state of Nevada. So where are we going to go, or are we going to take the same track that the federal government is taking?
We will work on contingency planning. We haven't quite gotten to that point yet, but there are several different options. The biggest problem that we have is that all of our funding right now is coming from federal sources. And I don't know if Director Mullenkamp can speak to what other possible funding sources we might be able to get mid-session, but that I don't know if there are any sources we can get mid-session without a special session. The other possibility is that the board might be able to, I don't know the legal ramifications of this, but might be able to form a nonprofit organization so that we could actually go and get a loan from somebody to do the rest of the implementation. But there are, we are thinking about it. I haven't really started the straight up planning or asking around for it, but we're getting into that. We still have a month or two to figure that out. And as Mr. Schultz indicated, a lot of our efforts are going into actually establishing the exchange as it is set up to be done today, assuming the courts don't overturn it. But yes, it is something in the back of my mind. If the funding goes away, how are we going to pay the staff of the exchange? Not just my salaries, but the salaries of all the people that are working for me, and the new employees that we hope to have by then, as well as the consulting services for the reports and all of those items. It is a concern of mine, and we will be working toward a contingency plan, regardless of what the feds are doing.
Madam Chairman? Yes. John, and maybe the AG's representative can help us with this at some point. It takes a little while to set up nonprofits, and I don't know if this is a process that can be done in parallel at the same time, so that we have a contingency that we can jump into if necessary. That's usually how I run my business, and I just have a small business. I don't have a large nonprofit corporation to run, but I always have the processes run parallel, so that if something does happen, I'm able to go into something quickly.
Someone in Dr. Klein, is that coming forward?
Now I'm back on again. Hi, Ron Klein in Las Vegas. Question to Herb Schultz and to the folks from CSIO. I'm sorry. One of the things we've been struggling with is just the essential benefits package and state mandates and trying to sync the two together, and struggling with whether we, to the extent that the federal essential benefits package is different than the state benefit mandates, whether we simply try to go to the state legislature and remove some of those mandates, or whether we try to achieve funding to fund those mandates, since my understanding is the federal government won't pay for any state mandates not part of the federal benefits package. Can you give us some insight into how other states are struggling with that, or what they're doing with that?
Well, let me make just a brief comment sort of overall, and then ask Teresa, who this is really in the scope of what she's doing sort of day to day. We have announced via guidance the intention of sort of where HHS want to head in the essential health benefits discussion. Where that has headed is guidance that put out an approach, a benchmark approach that is based off of the Children's Health Insurance Program. And so it is very much a state-based approach, not a federal approach. It is a state-based approach that says, here are possible benchmarks that the state can pick that are based on the plans that the state has. And for 2014 and 2015, what we have said is that if a particular benchmark is picked and it contains requirements, mandates, consumer protections, whatever that are there, that becomes for 2014 and 15 only, well, 2014 and 15, we'll look at it in 16. That becomes a part of the essential health benefits package. So there would not be a responsibility for the state at that time. As Teresa mentioned, we are working on draft regulations that would implement the provisions that we talked about in the guidance. But indeed, the approach is very much a state regulatory approach, looking at the health plan products that have been offered in the state. Not, one of those benchmarks is the Federal Employee Health Benefits Plan programs, but there are also your state small group plans, your state employees plans, your largest commercial HMO by enrollment plan.
I'm sorry, I wanted to clarify, I don't want to interrupt.
Can I just add one thing, I think that goes directly to your question. There is no federal essential health benefits plan that will be different than the state plan. So it's important to remember essential health benefits, when the state picks that benchmark plan, it's not just an inside the exchange issue, it's a market issue. So that essential health benefits benchmark that you pick as a state would be the essential health benefits package picked for both inside and outside the exchange. So there won't be a separate federal standard.
Okay. And I'm sorry, I just want to clarify, because I think it's different than what we understood, at least I understood to believe. So what you're telling me is that if we pick a state group health policy, one of the, I think, 5 choices we have, and that contains within it mandates that are not part of the federal federal essential health benefits package, then in 2014 and 2015, there will not be a financial impact to the state.
Okay, yeah, well, but let me underscore one thing Teresa said. The first thing, there is not a federal essential health benefits package. In the federal law, it says here are the 10 required categories of benefits. But the approach is saying to the states, I'm saying to the exchanges, here are the benchmarks that you could pick. But those benchmarks are based on state health plans. So the only thing the federal law is saying is, here's your 10 categories of benefits, and then you choose from there. And you are correct, what we are saying is that the guidance that has been put out says that in 2014 and 2015, given that it will take states, stakeholders time to look at, legislature's time, governor's office's time, to look at what requirements are already in state law. If you pick a benchmark plan where there are mandates applied to it, that's part of the essential health benefits package, and therefore a state does not defray the cost.
Madam Chair, if I might. So I think the confusion lies in the 2 different parts of what we're looking at when we talk about essential health benefits and benchmark plans. There's a federal list of essential health benefits for which we are waiting on regulations, further definition of what exactly those 10 10 categories cover the specifics of it. The other issue is that 3 of the benchmark plans are federal plans that are offered within the state of Nevada. So of the 10 benchmark plans, 3 of those are federal plans. Those federal plans may not cover all of the state mandates that the other plans have to cover. If we choose a federal plan that does not have a state mandate, but then we are mandating coverage for this, whatever this mandate is, then the state of Nevada would have to come up with a way to pay for the portion of the premium, the premium tax credit of the portion of the premium that is due to that mandate. If we choose a benchmark plan that already covers that mandate, it's considered one of our essential health benefits, and it is covered, and there's no cost to the state. The issue is, if you add that mandate to the cost of coverage, it increases the premiums, and so it decreases the affordability of the plan, although it protects special populations. And the discussion that we're going to have in agenda item number 8 is regarding the key principles of the Plan Certification and Management Committee, and how we balance the protecting of special populations and the encouraging participation. If you increase rates, you discourage participation theoretically because it's less affordable, but then you protect the special populations and vice versa, so you have to consider that. So if we accept or select a benchmark plan that has all of the state mandates, we can expect premiums to be slightly higher than they would be if we were to select a federal plan that would not necessarily cover the state mandates. However, if we select a plan that does not include all the state mandates, one of the federal plans, then either the state would have to cover the cost of that premiums tax credit for the portion of the premium that's due to that mandate, or you would have to remove the mandate. Staff is currently working on getting an actuarial valuation of the 10 benchmark plans, and we have to actually do some alterations. One of the benchmark plans will have to be changed, but generally we're going to do an evaluation of the 10 benchmark plans and determine the difference in premiums at approximately a % basis. If this set of essential benefits will be 1 or 2% higher than this other set of essential health benefits or benchmark plan, and then we'll also look at the cost of the mandates, the differences between the plans, and what those costs would be. So we are looking at that. We hope to have that to the next Plan Certification and Management Committee meeting that will be in May. Again, the one that was next week was canceled. So I think that might clarify the discussion a little bit.
Dr. Klein, does that answer your question?
Yes, thank you. That was very helpful.
Again, Herbert, Teresa, do you want to add any more to that? Because I mean, that really has been a heavy conversation with us in that committee as to what cost the state might bear depending on how you approach these mandates. So. Do we have any other questions here in Carson City? Back in Las Vegas?
Yes, I'm sorry to continue the discussion, I guess, and maybe, this is Lynn Atkins, and maybe because a couple of us weren't at the subcommittee meeting, I'm hearing Herb say something different than John, and so I'm confused.
For the record, John Hager, yeah, there's 2 separate discussions about what's federal and what's state. So there's a federal list of 10 sets of essential health benefits. Those essential health benefits will be covered if it falls into those categories and under the definition that we will hopefully soon have in the next month or 2, hopefully, then we should have a better definition of what exactly needs to be covered. If it's included in that set of essential health benefits, then that's required to be provided by the qualified health plans, and there will be no additional cost to the states for the premium tax credit for anything that's different from what we currently have in the current one of the 10 benchmark plans that we select. So that's a separate question from what the federal health plans are, the 3 federal health plans that we can select as benchmarks that may or may not have the mandates in place.
I think the
State
other way of answering this too is the concern is that Nevada's mandates may be richer than those at the federal government's level. And if they are, if we continue to want to have them as part of the health insurance exchange, what impact does that have on the general fund? What impact does that have on premiums? And who wants to play in that market?
And so just to clarify, I think we are in exactly the same place, because what we're trying to do in the approach is provide as much state flexibility as possible so that you can pick the best benchmark plan for the marketplace that you have, and every exchange, legislature, governor's office, stakeholders are grappling with that whole set of issues of balancing out which particular benchmark product works best for consumers and small businesses in Nevada. So I think we're all saying the same thing.
We have another question down here.
This is Jan Crandy again. This is just a follow-up. So if under the essential benefits 10 items in number 5 where it says including behavioral health treatment, if the intent was to include autism treatment and our state has an autism mandate, then that would not have an additional cost in 2014? Is that what we're saying? If it is part of this benchmark list.
If it's part of the benchmark plan that the state selects, then that's correct.
Any other questions or discussions here in Carson City? How about in Las Vegas? I can't tell.
We have one more question.
All right, thank you.
Hi, George Ross. Will non-qualified plans still be allowed to operate outside the exchange?
Qualified health plans, I think, will be the health plans offered in the exchange, but health plans that don't offer or don't meet that qualified health plan status, I think, are still allowed to operate outside the exchange.
Thank you.
Any other questions down in Las Vegas?
And I would just say, Madam Chair, as a closing comment, again, we're going to continue to be here and listen. These are great sets of questions, and so I gave the email and the cell phone, I hope, for a very genuine reason, and that is people are having these conversations every day. I've been having on the autism side, so I appreciate the community being there almost every day, as well as just these questions come fast and furious. So we hope that you'll utilize us in the region as a day-to-day source, pulling off of Teresa and our colleagues in DC as well. But we expect the questions are going to continue, not just sort of when we're not here. And so we've committed, obviously, to the governor's office, to the legislature, to the board, and to the community. So do not hesitate to use that cell or the email.
Thank you very much, and I appreciate you taking the time to come and visit with us all day today. So if there aren't any further questions, either in Las Vegas or...
Hi, Madam Chair, it's Larry.
Go ahead. We do have another question. Go ahead, please.
Thank you, Ms. Campbell. Hi, Madam Chair. Larry Hurst, representing Anthem Blue Cross and Blue Shield. Just want to bring up a point regarding the enacted statute, NRS 695I.210, power and duties of exchange. Under 1 Section E, unless the federal act is repealed or held to be unconstitutional or otherwise invalid or unlawful, perform all duties that are required of the exchange to implement the requirements of the federal act. So I appreciate Mr. Hager is looking at a contingency plan should something happen from SCOTUS. I just want to bring up that point on the enacted legislation. Thank you.
For the record, John Hager, and so that section or subsection of the statute directs the board to enact all sections of the Affordable Care Act unless it's otherwise unlawful or held unconstitutional. The rest of, so if it's held unconstitutional, we don't have to implement the requirements of the Affordable Care Act, but the rest of that entire chapter says set up a state exchange.
Thank you.
Any other questions or comments? Herb and Teresa, I can see you leaving, so I hope you'll stay and people can ask you questions. Okay. Again, thank you for taking as much time today as you have this morning and this afternoon with us. Next item on the agenda is the approval of the minutes from January 12th and March 8th. And I think we had a point of clarification on the January 12th minutes. And John, do you want to go over that clarification point so we can approve those minutes?
For the record, John Hager, and I, top of my head, I can't remember what it is right now. Ms. Atkins had the issue with it. I sent the revised minutes to her actually twice. We didn't correct them properly the first time. The second time, we took another listen to the recording and sent it back to her. She said that she was fine with it. I will let her clarify if she had any issues with it, but I think the minutes have been corrected. I think it had to do with a motion by Ms. Johnstone and an adjustment to that motion.
John, that's right. This is Lynn. It was the, if I might, it was the MOU discussion, and it has been corrected, and thank you.
Lynn, do you want to go ahead and make a motion to approve that then?
Sure, I'll move that the January 12th minutes are approved as amended.
All right, so we have a motion by Ms. Atkins. Do we have a second?
Second. Klein seconds.
Dr. Klein seconded.
Okay, we have Dr. Klein seconding. All those in favor of the motion?
Aye.
Anyone opposed? Thank you very much. Then we have the minutes from March 8th. Do we have any additions or amendments or edits to those minutes? If none, may I have a motion?
I'll move approval, Madam Chair.
Okay, we have a motion by Ms. Johnstone. Do we have a second?
Second the motion.
All right, Ms. Kerr has seconded. All those in favor of the motion?
Aye.
Anyone opposed? Motion passes. Thank you very much. Mr. Hager, your executive director's report.
For the record, John Hager, I actually went through most of the establishment grant request portion. As you can see, the latest grant request on March 29th was $4.4 million, and we'll cover that in a little bit better detail under agenda item number 7A. You can see that our total requests so far, our total awards were $20.3 million. When you include this latest request, if we receive that entire amount, if we get awarded that entire amount, it will be $24.7 million. And again, we're going to go back. I'm going to go back to the well one more time for the level 2 establishment grant, and we're hoping that that will be the last request that we need, that our planning is proper and everything is set up. One item to note, and we'll cover this again in the board or the committee recommendations. We'll discuss it. Previously, we thought that the guidance, well, let me back up. The guidance indicated that funding of exchanges would be provided, funding would be provided for the establishment of exchanges through December of 2014. And we focused on the fact that there would be funding through December of 2014, our understanding that that would cover all of the costs of the exchange. Since then, we have been notified that it does not include maintenance and operations, only establishment functions. So while while we will likely go live January 1st, 2014.
Can we get you to turn the mic off down there? We're getting a lot of feedback up here. Thank you.
So while we are going live January 1st, 2014, we could receive funding for things that are updates, tweaks. If we found something that we needed to implement to establish the exchange or better establish the exchange, we could get funding for that. But we would not get any funding for the ongoing maintenance and operations. Now we are speaking with SSHIX and trying to get a better clarification of that. It is staff's position that establishment of an exchange not only includes the technical implementation, it's the research, it's the implementation of the technical pieces, the web portal, the vendors, the DD&I, the design, development, and implementation, all of those processes, but it's also establishing a good business environment, which includes providing low costs, low PM fees, if that's the direction we decide to go, and gradually building those up so that we don't shock the market. We're already going to create quite a bit of disruption in the market by the entire exchange concept on January 1st, 2014. The last thing that we need to do is add an additional disruption where we have huge costs for the exchange. The first year of the exchange, while we will get as much enrollment as we possibly can, we expect it to be lower and gradually build up. Well, when you do that, your fixed costs that you have to be divided among a smaller portion, number of people, and that creates a higher per member per month cost, almost double what we had expected originally. It is still close to the amount that is typically part of a sustainable exchange. Those nonprofits that are out there providing exchange services are profitable, or not profitable, they're nonprofits, but they have been running for 10 or 15 years at the 10 to 12 per member per month, $10 to $12 per member per month amount. We're looking at $12 to $13, so we're right on the edge of that, and gradually bringing that down over time. Of course, that depends. That assumes that our assumptions on the cost of the eligibility engine and the BOSS RFP are accurate. Those could change, but my concern is that we have to create higher costs in the beginning. It makes it less. It makes it more difficult to gather enrollment, to get enrollment, especially if we end up with the Supreme Court taking away the mandate portion of the act. So we're cross your fingers that doesn't happen for the implementation of the exchange, anyways. And so this increased cost. The other side of that is at some point we need to build up a reserve so that we can pay our bills on a regular basis. If you are a for-profit or non-profit company, small business, large business, or in your MBA class they say cash is king, cash, and more cash. You need to be able to pay your bills. Even if you're profitable, if you don't have cash, you can't survive. So one of the important functions of establishing exchange is establishing a reserve, and a 20, 30, 40-day reserve should be sufficient. So under the assumption that we were going to receive maintenance and operating costs in 2014, we were able to create a PM fee based on the information that we have right now. That was about 70% of the long-term costs, and create a 30 to 40-day reserve, gradually build that up by a small amount each year until we reached in about 2018 the steady state amount. Again, these are all very preliminary numbers, but the point of this is based on our current expectations. The not being able to get that maintenance and operating costs results in a decrease in our expected funding of about $12.6 million in calendar year 2014. It's a concern. Again, we're working on with SSHIX to see if any of those portions of the exchange can be considered establishment. We hope that they will consider it establishment, but we'll have to wait and see. So that is, well, I guess it's not the condensed version of page 2. But in any event, we have also indicated that we're going to go back for our level 2 establishment grant. On to advisory committees on page 3. We've had 10 advisory committees resulting in 9 recommendations, and there might have been some confusion on the finance and sustainability committee, so we'll talk about that when we get to that section. But there were, anyway, at any event, 9 recommendations in the report. We have 3 additional advisory committee meetings scheduled for the remainder of April. And then finally, in, I think it was March, the board asked what the tribal membership was, number of Native Americans in Nevada. Director Wilden has indicated that there are, the last estimates indicate there's approximately 17,000 tribe members in Nevada. One other item is there was a discussion on federally recognized tribes versus tribes that were not federally recognized. And it appears that the ones that are not considered federally recognized tribes are actually subsets of those federally recognized tribes. So that should not be an issue going forward on determining tribal status, as long as we are provided with the correct tribal information from the participant, or there's a list, and we'll have to figure out exactly how we implement that process. So, but that discrepancy should not be an issue. And with that, I'll be happy to take any questions.
Do you have any questions from Las Vegas? Doesn't sound like it. Any questions here in Carson City? Okay, thank you. The next item then on the agenda is the review of Business Operations Solution Request, also known as BOSS. And Shauna is going to take care of giving us that report this morning. And that's item number 6.
For the record, this is Shauna DeRose. This report provides a summary of the Business Operations Solution Request for Proposal, the BOSS RFP. The RFP was released on March 26th, which was 4 days ahead of schedule. We had a deadline to submit questions to the RFP as of April 4th. We received 304 questions to our RFP, and we are in the process of formulating the answers to those questions and putting the answers back into an amendment to that RFP and posting that on purchasing's website. The RFP is attached to the agenda. It's a rather large document, so unless you want to take that to bed with you some nights or let you go to sleep, I don't think we need to review that too closely. One of the concerns that we have is the overlap of the CMS approval of the contract once we have a negotiated contract, and the approval of the contract by the State Board of Examiners. To get the contract to the July Board of Examiners, we have to provide a signed contract to the Budget Office somewhere around June 15th for the July BOE. In order to do that, we're on a very tight time frame, a very tight turnaround. We did have a couple of requests from the vendors to extend the time. We are looking at that. We haven't made any final decisions on that at this point. But when the amendment to the RFP goes out with the answers to our questions, that information will be provided as well. The table on the second page shows the original milestones for the RFP and the plan for all the way through the BOE approval. CMS approval and BOE approval will run concurrently, and hopefully we'll have that contract at the July BOE. And with that, I will answer any questions.
Any questions in Las Vegas? Okay, any questions here in Carson? Yes, Mike Wilden.
Just one from your nosy neighbor. So Sean, I'm just a little bit confused. I want to make sure I understand that. So the questions, responses to the questions should be out April 12th, and then the vendors' responses are due. I see select the vendor April 30th. So when are vendors' responses due?
In the original RFP language, it said that the vendors' responses were April 27th. They were due April 27th. And as I stated, we've had a couple of requests for an extended period of time to allow them to work on that RFP proposal. So we're looking at the timeframes. We're looking at how much time we could give them versus us having to review all of the RFPs and go through the evaluation process and still get to that July BOE.
So is April 12th doable? Isn't that today?
It is today. The plan is to have that out. It says on or about April 12th, so the plan is to have that out either late this afternoon or tomorrow morning.
Shauna, when you have over 300 questions on it, does that indicate that we've got some issues with the RFP?
Many of the questions revolved around the technical specifications and clarification of points. We did, and I would also say in comparison to the over 1,300 questions that California got on their RFP, that 300 is not so bad. So we were able to answer all the questions within the time frame, and working on the last few, working with the Division of Welfare and Supportive Services and the Medicaid staff to make sure that we are providing a response to the vendors that clearly answers their question.
And when you're stating that the questions are some of the technical questions, are we? I know we talked earlier today that we're waiting for some of those technical issues to be developed in guidelines or in regulations at the federal level. Are those questions related to those regulations as well? And maybe Herb might want to jump up and help address this too, because this is part of that tight timing that we keep talking about.
For the record, John Hager, we have designed the RFP so that it is flexible in the points that have not been provided by the feds so far. So the technical questions surrounded more of the what kind of IT infrastructure do you have in place? Do you have Microsoft Office or do you have Linux? You know, that kind of a question, and not that specifically, but that kind of question. So we've utilized the Brainiac IT folks that know how to answer those questions, and they've done a great job getting that information back to us. There were a lot of questions in there that were asked that the response was, we'll see this section. Okay, what do you think about this? Well, it's written over here. Well, what do you think about this? Well, it's written over here. It's such a large RFP that they're getting their minds around it, and so asking the questions, it basically helps us direct them to where the answer is located in the RFP. 300. I've never seen an RFP with the state that had 303 questions, but I've also never been part of an RFP that had 130 pages or whatever it was. It was a very large RFP, very specific on a lot of different details. It's a new project, so we try to be as specific as we could because people don't know what this is all about. They're learning about it. So we wanted to make sure everything that we could possibly think of was in there. There were certainly questions from vendors that we thought, what, if you don't know that answer, maybe you don't know enough about exchanges to be doing business with us. So, and we will see that in their presentations or in their responses if that's the case. So there was a whole broad range of questions. I'm not concerned about the strength of the RFP. Actually, Director Molenkamp sent me a note that said it's a very thorough RFP, and so as the head of the director over purchasing, it makes me feel good that we're actually on the right track. I will say I really do appreciate the support that we received from the purchasing division. They have been champs turning this around in very tight time frames, and we really do appreciate the help that Greg Smith's folks have had for us.
This is Leslie Johnstone. Is there time in the RFP review cycle to have demonstrations from the finalists?
Yes, this is Shauna Drews for the record. Yes, there will be, once all of the proposals come back in, the evaluation committee will be able to review, and then there will be, usually there's a natural break in the scoring, so I can't say the top 3 or the top 5, but there will be invitations sent out then for a presentation of the top vendors.
Any questions from Las Vegas? Any more questions here in Carson City? Okay, thank you. All right, the next item is item number 7, discussion and possible action regarding the financial report for the quarter ending March 31st, 2012. And Shauna DeRoos.
be taking this item as well. Again, for the record, my name is Shauna DeRoos. Item number A, under agenda item 7, is the review of the level 1 establishment grant application that was submitted on March 29th. John has gone over a large amount of this. I'm not going to read 18 pages here to you, but did want to say that the grant will cover expenses related to the BOSS implementation. It will relate to the work that we need to do with our sister state agencies, with Medicaid, with Division of Welfare, with the Director's Office. We've included funding for change management. We've included funding for work with vendors for risk adjustment and reinsurance. And there is obviously just the general operating salaries, computers, things like that that John mentioned earlier that will take us through this next year of funding. I don't want to take up a whole lot of time on this, but if you have any questions, then I would answer anything you have.
Any questions here in Carson City? How about, Ms. Johnstone? What kind of flexibility exists to reallocate funding between categories? Let's say the grant is approved at the level of specificity that's included in this document, and then after the fact, there's an identified need, more in consulting, less in consulting, for instance. Do you have the ability to transfer money between categories, and how long does that take to get approval for it? The HHS policy statement on these grants is that, so you say you had travel, like you said, and needed money in consulting. Generally, 25% of a grant can be reallocated without prior approval of the federal partner. So we can do that in-house. If it turned out that we needed more than 25% of that, we would have to go back to our federal partners, and I've actually not done that. So Brandon, can you state how long that usually takes to turn that around if it's more?
I think we aim to make it as flexible as possible, as expedited as possible.
Excuse me, Brandon, we have people down in Las Vegas that'll want to hear your answer, so if you wait just a second so we get you a microphone. Thank you.
Thank you. Typically that cycle time would be about 30 days, but we aim to make it a bit more expeditious to meet the state's needs.
And we appreciate that very much. Thank you. Now we have another record. Yes. Did that answer your question? Mike Wallen, did you have a question?
Not so much a question as a statement. Thank you, Madam Chair. I just wanted to point out for the board and actually for our federal partners that on page 11, as Sean said, she's not going to drill down through it, but one thing that's particularly of interest, concern to me is the cultural change management piece of this grant. We talked with our federal partners this morning about just how big of a deal this is. You know, John and Sean are running hard, doing yeoman's work, but you know, you got thousands of employees out there in my organization that this is just a huge cultural shift and resizing of all kinds of things, how we do business, and this is a really important piece of work, so I hope the feds are very favorable about this. So I guess that's to you, Brandon. This is just, you can't even, I can't say enough about the cultural change related to this event. It's huge. Everything we do changes.
Thanks, Mike. Yes, John?
For the record, John Hager, and just to, when you go through the notice of award process, there's a budget discussion between the awardee and the federal government, and so we will make sure that you guys are represented, that you or Chuck or Diane or all of you are there available to be on that budget discussion, and I asked Brandon to send those emails out. I will forward them as well, but we'll make sure that you're part of that discussion.
Do we have any questions or comments from Las Vegas?
right, status of the exchange budget. Shauna, are you doing that one as well?
I am, thank you. Item number 7B is the budget status report for quarter ending March 31st, 2012. Each quarter, we present the actual status of the exchange's budget for your review. This is the third quarter budget report for state fiscal year 2012, and this report covers the expenditures for the planning grant and the level 1 establishment grant. The planning grant has been fully obligated as of March 31st, 2012, although actual payments on some items are still pending. The planning grant was expended per the authorized budget with an 8% variance for reallocation, primarily due to salaries and benefits being moved into the contractual category while those salaries were paid out of the establishment grant. The establishment grant is divided into 3 portions. There is funding for the exchange, for consumer health assistance, and for the Division of Welfare and Supportive Services. The exchange has expended approximately 10% of its annual budget as of March 31st. Fiscal year 2012 expenses are on target to be at about 65% of the annual budget as of June 30th. As has been discussed at previous meetings, there have been various reasons for the minimal expenditures at this point. We had delayed hiring of the staff. There's been some contractual delays, things like that. Any authority left over from the level 1 establishment grant will roll over into the state fiscal year 2013. We have through August 14th to expend those funds, and I believe that all of those funds will be expended by that date. Consumer health assistance has expended about 3% of its annual budget as of March 31st, and the Division of Welfare and Supportive Services have not yet spent any portion of their grant to date. The funding for WIS is entirely for the eligibility engine, and they are just now going through their RFP and getting theirs on board. So this will speed up very, very quickly now. And so that money will be expended through August 14th as well. There are 2 spreadsheets that are attached. The first one is for the planning grant, and it shows kind of the life cycle of this grant, how there was originally $304,000 that was expended while the grant was, say, housed over at Medicaid, and it shows expenses through March 31st with a grant balance of about $85,000, and as I said, that $85,000 has been obligated. We just haven't actually cut those checks yet. So the grant balance on the planning grant will be 0 at June 30. The next page is the establishment grant, and again, it goes through this 3 sections: the exchange, consumer health assistance, and the eligibility engine at WIS. We are on target, I believe, to have about $280,000 that will roll over into the next fiscal year and be fully expended by August 14th. And that concludes my report. If you have any questions.
All right, let me ask you something. You have it marked for possible action. Can you tell me what action we need to take on either one of those reports?
You could either accept the report, but there's no action is required.
Okay, from a policy standpoint, do we need to be accepting your quarterly reports? I mean, I don't know what the protocol is, so give us some guidance here on that.
It's really up to the board. I mean, if you want to accept them or make a motion to accept them, that's fine, but if you don't do that, it's not really going to happen. At least as far as I'm concerned.
Do you have a preference, John? As director, what would you like to see done?
The fewer motions we have, the shorter the minutes are.
All right.
I believe the possible action would be if you were to ask to change something or require clarification, I would need to come back. So.
All right, thank you very much then. I don't think that we need any action on this item then. Why don't we take about a 10-minute break right here, and when we come back, we'll finish the rest of the agenda. Item number 8 is probably going to take the majority of the time for the balance of the meeting. So,
and Madam Chair, you indicated that you wanted to start with item 10 and then go to 8?
Yes, I do want to change the order of business on here. The key principles that we'll be talking about in item number 8 are directly related to our strategic plan in item number 10. So I'd like to go over the strategic plan one more time and then walk into the key principles of the subcommittees. So we'll take a 10-minute break. I don't see, is there a clock? It's 2 o'clock? We'll come back on about 10 after 2 then.
No, we told him up front, thank you. Sorry about that. We just decided the way this was that we probably should do it this way. So I said it to John, so thank you.
Perfect. Okay.
Yes.
Yeah.
I guess I assumed
We didn't set up the
Good to
phone
see
call,
you.
right, at all? No, For people because to call nobody in. needed to call in.
Okay, so I've given the insurers the call-in number. So it's too late now, but every meeting will have a call-in number available.
Okay. And, okay.
It's okay. No worries.
And you do have a new number, you gave them a new number.
Are you talking
It's
about
all right.
just your plan versus the multi-state payment plan? It's just separate from essential health benefits. We're not talking about Yep. Yep. I was a state regulator. This is a big issue.
Yeah.
And it's one that OPM
Pretty much right after I was there, starting September.
we have
I have no idea.
And I was the tree commissioner.
Hey, Danny, it's so are you watching it? I got a couple of them. Why? I suck at the camera.
So I get it. OPM's leading it, and so we're doing everything we can.
What? You can't see me. All right, and then you got everybody connected over there?
You know,
What was the problem?
I used to drive you crazy.
Right?
Yeah.
That little checkbox?
Because then it's not just your timeline, and then to the White House that we always go and discuss all of it there.
Good to see you again. You have a budget.
I have no idea. Yeah, but it's a huge issue. I'm Lisa Foster. I'm good.
I'm good.
Thank you.
Oh, my pleasure.
I want to see how it last, not the last meeting, but the one last year, when I was still regular. And we met.
With the legislature? Yes. There were 2 members of the legislature, somewhat similar to this, although they had a lot of questions about essential health benefits, about the IT systems, whatever, a lot of that stuff.
How did they even get in there?
Maybe a 15-minute discussion, a full hour.
I appreciate it. They were about
Yes, let me make sure you have
like market conduct.
that. Right. So now where are you going to start?
Licensing. So they wouldn't come out and say, because we just kept saying, rules here that everything that other plans
And it doesn't help them to
state plans are doing, and they wouldn't come out and say that. So state regulators are not placed to help answer right now. And like I said, I think
To make sure that I can help troubleshoot, even if it's an operations issue, still going to affect the policy or whatever it is, just let us know. Because my role is
before you let the multi-states in.
in the immediate office of the
Yeah, I
secretary,
don't
so
know
I
how
can
much flexibility is in the
take
statute,
things.
or if OPM's talked about that or thought about it.
A little over 2 years. A little over 2 years.
We're trying to engage with them, but.
Well, the statute is silent, you have to.
So,
Right.
you know, it's now that I
And I haven't looked at it along its, so I'm not really sure.
It finally feels
what
like I
that-
have to.
Yeah, and like I said, we
For
haven't
so
done
long,
that ton of
it's like,
conversation.
you know,
I think
for so
we
long
understand
it
the
was,
issue, at HHS, it's just really
you know, deputy president.
He just in the beginning, and I haven't even seen or heard from Daryl, and he was the one who checked me with the
Other
online
than
piece.
I feel your pain and I hear you, I have the same exact concern. And every exchange I talk to has the same concern.
Well,
Yeah.
when we did that
You
test,
bet.
he said that it would just kind of periodically change. It's not gonna change on who's speaking.
It is in this administration, you know, it's, you know, not to be critical of any other administration, Democrat or Republican. I work, just as an FYI, I work with Lloyd and everyone up and down CHW, so let me know how I can help. And I was actually in the hospital a couple of months ago, not in the, but I was with the Human Services Network in the hospital, founded it. So, had me sort of over there. So now that you have dignity is
Take care. Good luck.
Oh my God.
Dr. Ford, can you help me get everybody organized in Las Vegas, please, and we'll go back on the record?
Hang on, Barbara, it's muted right now.
Oh, no wonder they're not responding.
There you go.
Are we? Can we get everyone organized in Las Vegas and we'll go back on the record?
It's not muted. Is it muted? They can't hear us in Las Vegas. What? I don't know.
Dr. Ford?
She's talking.
Maybe they got it muted.
They have it muted?
They may have their side turned down or something.
Yeah, we're trying to get everybody's attention right now, Barbara.
Thank you.
Mike T's on.
All right, I think we have everybody ready. Let's go back on the record then. And we're going to go out of order right now. I'm going to ask Mr. Hager to talk about action on our exchange strategic plan. That strategic plan is very important with regard to the key principles that we'll discuss next from the advisory committee. So, John?
For the record, John Hager, Executive Director. On Monday, I actually considered taking this off of the agenda altogether. If you read through the goals and objectives, they were not particularly strong goals and the objectives, excuse me. The goals were already set by the board last month. The objectives were not particularly strong, nor were the measures. So I'd like to bring this back for the next board meeting in May. And again, I don't think this will push us back too far. We're on track for implementing the exchange just fine. However, there was a little bit of confusion in the minutes, and so I would like to go to attachment A, which is the vision, mission, values, and goals that the board approved at the March 8th board meeting. There was a lot of discussion about changing the negative to a positive and increase the number of insured persons in Nevada. However, when we got to the motion, there was no mention of that, so I want to make sure that the board clarifies in a motion that they approve this language. Additionally, in goal number 4, provide consumer education on matters relating to health insurance, there was a comment about including language about enrollment, but it wasn't very specific. So I would ask the board to reaffirm or approve the vision, mission, values, and goals as stated here, and absolutely feel free to tweak the language in number 4 or any of the items for that matter. It's your strategic plan, but I just wanted to make sure that we have it a solid plan and the appropriate motion on the record.
Thank you, John. And if I'm not mistaken, I think, Lynn, it was you that liked to put things in the positive instead of the negative. So, if everyone's
Yes.
Have you had a chance to look at the goals to see if they more accurately reflect your thoughts?
Well, I'm looking at them now. So if we could have just a moment.
Okay.
And I will say, Madam Chair, that other than items 1 and 4, the rest of this was exactly as the motion indicated. Although there are multiple motions, but they're exactly as the board indicated in the motions. It was just items 1 and 4 that I think needs some clarification.
This looks right to me. Unless am I missing something, John or Madam Chair?
No, I think that what John's doing is he's trying to true this up to the motion that was made, and our motion at last meeting missed some of these clarifying points that we had discussed. Ms. Johnstone?
Thank you, Madam Chair. Now I don't remember exactly the conversation that we had around number 4, but looking at this wording, I wonder if instead of enrollment in and efficient use of health insurance, that it's educating them on enrollment and effective use of health insurance so that they're a good consumer and it's meaningful to them, not just focused on the efficiency of it.
And I will say that the board approved provide consumer education on matters relating to health insurance, and then include some language about enrollment. And so adding just enrollment by itself sounded kind of weird, and so I added efficient, but effective or responsible use would be probably better terminology.
All right, John, you want to read that one more time with your corrections or amendments?
So item number 1 would be to increase the number of insured persons in Nevada. And item number 4 would be to provide consumer education on matters relating to enrollment in and, Leslie, did you say effective use of health insurance? And you could use either effective or responsible. I think it's better than efficient, though.
Do you have a preference?
I don't think I have a preference.
This is Lynn. I like effective better than responsible.
Any other comments from board members? All right, number 4 would read then, provide consumer education on matters relating to enrollment in and effective use of health insurance. So if there's no further discussion, may I have a motion to approve the strategic plans with the amendments made under goals to item number 1 and number 4?
I would so move.
Second.
We have a second from Marie Kerr. Thank you. All those in favor of the motion?
Aye.
Any opposed? Motion carries. Thank you. Now, does that take care? John, let's just briefly go over the strategic plan because that's important as we move into item number 8. So the vision is access to health insurance for all Nevadans. If you want to take it on mission from there and our values.
And the mission as approved by the board is to increase the number of insured Nevadans by facilitating the purchase and sale of health insurance that provides quality health care through the creation of a transparent, simplified marketplace of qualified health plans. The values include consumer focus. At the center of the exchange's efforts are the people it serves, including patients and their families, and small business owners and their employees. Innovative. The exchange strives to be an innovative and forward-thinking organization. Diversity. Diverse stakeholder involvement is vital to a successful implementation of the exchange. Business-friendly. The exchange is committed to creating a business-friendly environment for the simple purchase of health insurance. And there are 5 goals. The first is to increase the number of insured persons in Nevada, facilitate the purchase and sale of health insurance, assist qualified employers in the enrollment and purchase of health coverage and the application for subsidies for enrollees, provide consumer education on matters relating to enrollment in and effective use of health insurance, assist residents of Nevada with access to programs, premium assistance tax credits, and cost-sharing reductions.
And I think that's a good lead-in now to the reports under item number 8, which are recommendations from the advisory committee. And within those recommendations, you'll see the key principles being developed with within each one of those subcommittees. And I have asked that the chairs of each of those subcommittees give those reports today. And John, did you want to get us started?
Yes, ma'am. So for the record, John Hager, just a couple of comments. The committees made recommendations, however, some of the recommendations were not complete thoughts per se, or they were, similar to that last one about provide some language about enrollment. So I provided language about enrollment in that case. In these other cases, you'll see that we provided information that I think provides the spirit of the recommendation where there wasn't specificity in the language. There are also a few changes as we go through this. We find out new things all the time. It's difficult to have off the top of your head a 500-page regulation that was just provided on March 12th. So we find out things all the time and try and update them where we can. So there's a couple of things that we realized had changed, so I try to put those in either the blue underline or red strike through so that you could see where that had changed or gone off of or different from the recommendation of the advisory committee. And so we can certainly discuss those items as we go. But as Chair Campbell indicated, we have asked the chairs of the individual committees to discuss their recommendations. Chair Lewis is not here, excuse me, and she is the chair of the Finance and Sustainability Committee, so I've asked the Vice Chair, Lynn Atkins, to provide the recommendations on finance and sustainability. In reading this report, she indicated that she doesn't think that we've provided any recommendations specifically on the way to get revenue going forward. And so we will provide this information as information for the board, and we'll go back to the Finance and Sustainability Committee for that particular item. But there's a couple other items in here that she can continue with. So with that, I'll ask Chair Atkins, or Vice Chair Atkins of the Finance and Sustainability Advisory Committee to provide this section of the report.
I'm going to go through some of the materials here, but I'm not going to read everything. If anybody wants me to get a little bit more detail, please let me know. But the beginning portion, the Finance Sustainability Advisory Committee is charged with studying the different financing options that are available to the healthcare exchange and providing recommendations to the board. We have three main goals, which are one, we have to come up with methods by which the exchange can be self-sustaining in compliance with the Affordable Care Act. We're talking about user fees, licensing fees, and other assessments that may help us towards that goal, and also discussing any legislative changes that might be required to move us forward. One of the first things we did was adopt key principles to guide the decision-making process regarding finance and sustainability. There are 8 guiding principles. The first one is stability, reliability, and predictability. The second one is just encouraging participation, so we could have lots of participants in the exchange, therefore hopefully spreading out the cost of the exchange. Minimizing adverse market impacts. We want to be financed in a way that will minimize adverse market impacts. We want to be flexible. The initial cost of the exchange is going to be high, and enrollment is expected to increase over the life of the exchange. And enrollees, with initial enrollees primarily being those who are eligible for premium tax credits and cost sharing. So that's a concern of ours. We want to have sustainability options If the state wishes to frame the exchange as a business, then the financing could be dependent on those who conduct business within the exchange, namely individuals and businesses purchasing insurance and carriers selling insurance through the exchange. We want to have routine monitoring, evaluation, and accountability. We want to prevent fraud, waste, and abuse, and be subject to routine evaluation and annual adjustment if necessary. We want to be transparent. Key principle of the Affordable Care Act and should be upheld in the financing of the exchange. And we want to make sure to protect special populations. We want to make sure that the Affordable Care Act is affordable for vulnerable and underserved populations and protect them from excessive user fees and other harmful barriers to coverage. Did I go over that too quickly?
It wasn't too quickly for me. I don't know if anyone else wants a little more detail. Ms. Johnstone?
This is Leslie Johnstone. As I was looking at this, I was curious on number 5, the sustainability options. If the advisory committee at this point had any consensus which approach to go in, or if that was something that the advisory committee thought was in its scope at all.
I think that's the item, the third item on here. I think that we are discussing, and we have a few different ideas, but some new ideas were brought up at the last committee meeting that staff is actually investigating to see if there's an additional revenue source. Is that right, John?
Yes, the initial thought was that the costs of the exchange should be provided by, the revenues for the exchange should be provided by those utilizing the exchange, much like a business. However, there are broader impacts, there are adverse selection issues, there are issues because of the requirements for qualified health plans to be the same inside and outside the exchange, not only in plan design, but also in the rates. If we only charge the enrollment in the exchange, those people that are enrolled in a qualified health plan outside the exchange are in fact paying that cost because their premiums are the same. So there's a lot of different things to this that we need to consider. We need to have some sit downs with various elected officials to see how far we can go on this and what items make sense to them. Under our current statute, the board has the authority to adopt regulations as necessary to carry out the functions of the exchange. It appears that we have the authority to create a regulation to charge a fee for enrollment in the exchange. I don't think that we have the authority to charge a fee outside of the exchange. So anything beyond charging fees for people inside the exchange would likely require statutory changes. And so if that's the case, we need to make sure that we have all our ducks lined up in a row. If we create a plan and then going forward in legislative session, we need to make sure we're going in the right direction. So we've talked with Director Mollenkamp and Commissioner Kipper, Director Wilden, about setting up meetings to discuss some of these options, and so we will be doing that going forward. So item 5, sustainability options, is kind of left open right now. There's 3 different possibilities. We can either treat it as a business, where if you're in it, you pay. We treat it as the exchange provides value to the entire market, and so financing mechanisms should be broader to include carriers inside and outside the exchange, maybe a fee for all small group and individual enrollment for the entire market. Or you say, this is a public good, it provides a service to everybody, it reduces the number of uninsured that aren't paying their hospital bills, that there's whole sorts of broader impacts, and so maybe there's another funding source as well. So we need to go and actually get some better guidance from our political policymakers and figure out where we should go with this. So sustainability options, without defining one of those 3 items, is not a great key principle yet, but it needs to be put out there as a starting point, I think.
So I guess the next item, recommendation 2, is the budget and expenditures, but do we want to do anything on the first item, John, or would you prefer just to move forward? And if so, I'm gonna have to ask you to kind of go through the budget and expenditures, because
Lynn, I'm not so
I'm
sure.
not gonna be able to explain
Mike,
this.
did you have a question?
I'm always full of comments, it wasn't so much a comment. I would suggest, and I think John talked about this a little bit when he talked earlier about you know, when you don't have the number of enrollees or participants early on, you have a heavier PMPM. And so one of the things I'd encourage you may look at a combination of funding sources and then ultimately get to one or the other as you get full capacity in the market. You may have to have some public good and then swing towards business or something like that. Or the PMPM is too high.
Well, and I think at this point, we're developing these key principles, but we haven't had the time to really work within them yet to establish, you know, methodologies that create that sustainability for us. So, but good comments. I hadn't thought about a shared responsibility on that. Lynn, do you have anybody up there or down there in Las Vegas that has any questions about your key principles?
No.
Doesn't look like it. And your recommendation is that the board approve the key principles that your subcommittee has developed at this point, knowing that all of these documents are living documents that will change as we feel that we need to change them. Is that correct?
Yes. Yes.
All right. Well, why don't we do the recommendations one at a time then? So do any of the board members want to make the motion to approve the key principles for finance and sustainability?
This is Marie Kerr, motion to approve. Sorry.
It's Dr. Ford, I second.
Thank you. All those in favor of the motion?
Aye.
Any opposed? Motion carries. Thank you.
On recommendation 2, I would have to ask John to take the lead on that.
Thank you.
Recommendation number 2 is regarding the budget expenditures of the exchange. We've asked the Finance and Sustainability Committee to go over the budget, both expenditures and revenues. We're kind of taking them in 2 separate sections, obviously. We've got expenditures here and then revenues. This is a starting point. Notice that it goes all the way out to 2017. I can guarantee you that our expenditures in 2017 will not be what are provided here, but we are trying to, the idea behind putting this out to 2017 is to take what we expect the expenditures to be and the enrollment as it increases as provided by our consultants, and kind of determine at what point it becomes more of a steady state fee. And based on the expenditures that we had here, it appeared, and the enrollment, it appeared that we get to a steady state using these expenditures, and you'll see this later on, of about $7.55 per member per month in 2018. So right off the edge of this item, we actually did this all the way up to 2021. Now that doesn't include inflation, so there's inflationary issues. We don't have the cost for the eligibility engine or the BOSS RFP, so that will create a significant impact to this. But in general, the salaries are based on the salaries that were approved by the board on March 8th. Now we do have a slight modification to that in our next agenda item, but you're talking pennies on a per member per month basis. So keep that in mind. The travel, you can see the summary for the assumptions for travel, operating expenses, equipment, IT. The transfer to welfare is for the design, development, implementation, independent validation and verification, and the maintenance and operating of the eligibility engine. And that's a guess based on what we think our per member per month costs will be. Again, that item will definitely change once we get the actual cost from the eligibility engine vendor. The consulting services include the business operations solution. Again, that's going to have a big impact on where we end up with that. Actuarial and consulting services for reinsurance and risk adjustment. That one, we're not sure if that belongs in the exchange budget. Number one, we might require the feds to do it, and that cost goes away altogether. It is broad-based, it's for the entire market, not just for the exchange. While it's being implemented because of the exchange, it affects all products in the small and individual market, or the entire market, small and individual. So I'm not sure if it belongs in the exchange. If we do a broad-based assessment, then maybe it makes sense to have it in the exchange budget. But if we're only going to charge people inside the exchange, it doesn't seem fair, if you will, to charge that group of people for a service that is applied to the entire market. So we're not sure where that goes, but for now, I think it makes sense just to leave it here until we figure out what we're going to do with that. The kiosk servicing, we provided a base guess on what we expect to charge for kiosks. We still need to have more conversations with the Department of Health and Human Services and Welfare to see if we can put kiosks in their spaces, or if we put kiosks in grocery stores, and that will come out of the advertising and marketing campaign RFP. Will figure out how that should go at that point. Obviously the marketing and advertising campaign, that vendor has not been selected, so that will be a variable cost. The independent auditor, that cost was based off of the audits that are done at the Public Employee Benefits Program. It should be pretty close to what we should expect. It might be a little bit less, but you're not talking a whole lot of money, probably less than $30,000. So out of a $21 million budget, I think we can give a little on that one. Program integrity and compliance auditors and other professional consulting services, just kind of a what if in there. So then navigator services were included in there, but that again will be highly dependent on the program that's provided by the Consumer Assistance Advisory Committee. The costs to pay our attorneys general, we do need to pay them at some point. We appreciate their services thus far, but we do need to pay them at some point, so we need to include that. And then there's a purchasing assessment and other statewide cost allocations that we've included in here as well. So a lot of assumptions. Please understand that this will change. We had to have a starting point so we can kind of get an idea of where we're going with this. And we will continue to bring this back to the board as things change, just to make sure that you are up to date on the latest information. So with that, the recommendation of the advisory committee was to approve the expenditures provided in this report, with the understanding that the updates will be provided as better estimates become available.
Lynn, did you want to add anything else to his?
No, I didn't, not on this section. There was a question if there was going to be public comment at this portion, so I didn't know what the answer was to that.
Okay. No, I don't object to public comment at this point. Is there somebody there that wants to ask a question or make a comment?
I believe so.
Thank you very much. Leanne Gasway with America's Health Insurance Plans. I'm a little confused on the transfer to DWSS. Is there an idea that this is kind of a one-stop shopping entry point for Medicaid eligibility as well as commercial insurance eligibility? But do we want to have the exchange taking on the costs of Medicaid eligibility, which is a state-funded and federally funded activity today, where that money should be actually flowing into the exchange to perform that eligibility on behalf? Or is there going to be a very bright line somehow where the exchange is going to push eligibility over to the Medicaid agency and not perform any eligibility in the exchange structure? Because I don't think we want to necessarily have that cost shift onto the commercial insurance market for doing eligibility for Medicaid. That still should be done by the federal and state government.
For the record, John Hager, and we agree. The eligibility engine is the back-end piece of the total business solution. So we have two major IT components going on here. One is the eligibility engine that has been put out to bid and is in the process of being selected. The vendor's being selected soon, and that piece is the part that is communicated. Well, let me back up. The BOSS solution, the business operations solution, is the front-end web portal, shop exchange, premium aggregator. That is the piece that will determine eligibility for the employers and the employees of the employers. It will not determine eligibility for individuals. It will be the front-end application that a person sees when they go to the exchange. So when you go to the exchange as an individual, you plug in your demographic data, the web portal will shoot that over to the eligibility engine, and the eligibility engine will then communicate with the federal data hub to get all of the items that, maybe we didn't talk about in this meeting, it was an earlier meeting that we talked about it. It will get modified adjusted gross income, it will determine citizenship status, all of the things that we need to determine eligibility. That information will come back to the eligibility engine, and the eligibility engine will say, yes, they are eligible for the exchange, for a subsidy on the exchange, and here's the amount, and puts it over to the exchange, to the web portal, and the information pops up on the web portal for the individual to see, and then the individual can make a determination on what kind of qualified health plan that person wants. They can pick their tiers, they can pick the cost of coverage, their plan, etc., and then they can enroll. But we have to be able to have a way to talk with the federal data hub and to get that eligibility information. One of the issues that we have is that the eligibility engine could get information back that says, you know what, you're eligible for Medicaid instead, so you should go to Medicaid. And so the web portal will either do a redirect to the welfare program, is it Nevada Checkup? Access Nevada, so it will redirect you to that website, or if you called into the call center, they'll redirect you to the welfare call center as appropriate. The other side of that is somebody can go into the welfare system to get Medicaid services. They do the same process through the Access Nevada system, and the eligibility engine says, you know what, you're not eligible for Medicaid, but why don't you go to the exchange and try and get coverage through them? So it will do a web redirect or a call center warm transfer to us. So no matter how you get in there, you will get the service that you need. So what's going to happen is, for the BOSS RFP, for the BOSS solution, we expect that we will have some amount of individuals that will come in that will be Medicaid eligible, and we will actually cost allocate that portion of our expenses to Medicaid. On the other side of that is there will be people that will go to the into the Access Nevada system, and they will be eligible for the exchange services. So that part, actually, I don't know if we talked about that piece specifically, but I would expect that would be cost allocated to us. On the eligibility engine side, the cost of the eligibility engine is more than what you see in this transfer to DWSS. On the design and implementation, yes, most of that is coming from Affordable Care Act funds and is provided here. But when you get into the later years for maintenance and operations, a good chunk of that is coming from the eligibility for Medicaid. So if Medicaid is 2/3 of the population and the exchange is 1/3, then you would expect to see 2/3 of the cost come from federal and state matching funds, and 1/3 to come from the exchange. Again, this is just a starting point, but the maintenance and operating that you see specifically in 2015, 16, and 17, that's just a part of it. It's an estimate. Again, we haven't gotten the information back. We are not paying for the services of we're not paying for the services to Medicaid enrollees. We are only paying for those services that are for exchange enrollees. How's that for a succinct answer?
That was one long sentence.
We have another question here from Dr. Klein. All right.
Hi, Ron Klein. John and Lynn, in terms of recommendation A, in terms of funding the exchange through a per month assessment, did you consider, and I don't even know if it's legally permissible, a third option, which would be to, under the public good rationale, have a per member per month assessment, not only the entire individual small group market, but the large group market, just to try to spread that cost over as many individuals as possible, and thereby decrease the PMPM for each individual?
John, correct me if I'm wrong. I believe we can't assess folks outside of the market without legislative action. Is that right?
For the record, John Hager, my interpretation of our statute, and I guess we could get a legal interpretation of this, but I would not feel comfortable creating an assessment in our regulations to the entire market, especially if it included groups that were not the small group or individual markets. I could possibly make the argument that we have the authority to do it to the small group and individual markets, but even that I'm not very comfortable with. We'll get into that discussion more on the revenue side. However, if we could, if you wouldn't mind, we could get a recommendation on the budget as of the expenditure side of the budget, and we'll go to the revenue side in just a second.
Do we have any questions here in Carson City on the expenditure side? And I see someone that would like to make public comment here. Hold on and we'll get a microphone to you. And if you would please identify yourself for the record.
Yes, my name is Elise Moss-Bedica, and I'm with AMD Healthcare Consulting, Inc. And my question is, I just want you to expound on the kiosk servicing, which is under the Exchange Consulting Services, Inc. Would you talk about that, please, the kiosk?
For the record, John Hager, one of the possible ways, well, I'll back up again. The web portal is the primary access point for services in the exchange. No matter how you access the exchange, it will at some point go through the web portal. Whether you are going directly to the web portal as a consumer, or you are calling into the call center, the person that's taking that call is going onto that web portal, because it all has to go back to the eligibility engine and then to the federal data hub and back again. If you walk into a broker's or navigator's office, we would expect that they would go through the same web portal. So all of that goes through the web portal. One of the ideas to make access, to make the exchange more accessible, is to put kiosks in high traffic locations, perhaps at a welfare office, where you might have people that are expecting to go into Medicaid, but they're on the lower end of the exchange eligibility, you know, at 138 to say 200% federal poverty level. Or maybe there are, maybe at the DMV locations or at grocery stores, or, you know, there's a lot of different possibilities, and so we need to consider them.
Okay, yeah, that's what I wanted to hear about the high traffic locations, and you mentioned, you know, a grocery store or something like that. And my question is this, do you really think that consumers, healthcare consumers, especially in that 500,000 of uninsured Nevadans, would actually enroll in something as serious as healthcare at a kiosk in a grocery store?
So
are the DMV? That's my question, because when you're making a decision about healthcare, it's not a 1, 2, 3. It really requires detail, and so that's why I'm questioning the kiosks.
Absolutely, and we have taken that into account. That will be looked at further by the vendor that we select as our marketing and advertising vendor to determine what the best locations would be for those kiosks. I think that, well, we have to do research on this, but likely a location at a welfare center for somebody that's expecting to get Medicaid coverage at that welfare location, that makes sense to put a kiosk there. Putting it out at a grocery store, that was just an example. We are considering all the options. We're not saying that that's where it's going to be.
Okay. And then my second question has to do with the, and this is on page 5, looking at the expenditures. This question is concerning the training. Is this training specifically for the employees of the exchange, or?
That's correct. It's specifically for training I think we're looking at 13 employees by the end of this. We're trying to keep it lean. So possibly $13,000 there. That would include conferences to, you know, if there is an insurance exchange meeting in DC where we can you know, pick up, you know, items of interest, that would cover fees, it would cover travel, stuff like that. If we do conferences in the state, it's a pretty typical amount for an agency this size.
Okay. And the reason why I asked about the training, I guess I was trying to tie it to one of the key principles of engaging the consumers or encouraging participation. So that's why I was asking about that. The training and the expenditures is for the employees, but the actual encouraging participation to enroll in the exchange, I was trying to figure out where that type of training comes to the public.
That is in category 50, the exchange consulting services. That is included in multiple places. One is the marketing and advertising campaign. There will be a lot of advertising going out, and that will include training. It includes category 55. The navigators will provide quite a bit of training, and we will be on the road providing training as well. And that would be in our in-state travel budget. You can see the in-state travel is actually quite a bit for an agency of this size, and we expect to do a lot of travel just on the staff to provide training as well. The training that's listed specifically in category 30 is training our staff. The consumer outreach portion of training is included in a lot of different places.
Thank you.
Thank you for your questions. Do we have any other questions from board members on the expenditure side? If not, do we have a motion to approve these budget estimates?
I can move to approve.
Is that Dr. Klein?
Sure, I'll move to approve.
Thank you.
I was waiting for Lynn to approve her own report, but she's shy.
I second Dr. Ford.
Okay, thank you, Dr. Ford. All right, all those in favor of the motion? Aye.
Aye.
Any opposed? Thank you, motion carries. Recommendation number 3 on the revenue side.
And I can talk about that, and John, you can fill in the blanks. And I don't think we're in a position to actually vote on this right now, but there seems to be lots of questions which are understandable about what we're discussing in the subcommittee. And I think where we kind of left everything is we're trying to think outside the box, and we're trying to come up with a lot of different revenue sources, a diverse revenue stream, in order to sustain and have the exchange successful. So I guess kind of the default suggestion is having a user fee and tacking on fees to premiums for folks who are using the exchange for their health insurance. But there's a couple issues with that, whether or not the federal subsidy will cover that, and it depends upon whether it's an add-on fee after the premium or whether it's part of the insurance coverage where the insurance company kind of builds it into their price. And then there's questions, though, about carriers meeting their medical loss ratio and how that might fit in. So the committee was talking broadly about how that might work, how much it might be for an individual or for a family. And then we kind of morphed into a discussion of, well, gosh, the Affordable Care Act is supposed to be benefiting the entire state. And, you know, should there be a broader pool of people, or should it be part of legislative action to help subsidize, to have this be as a successful program as possible? So we started talking in that sense. We also were getting some more information about the additional income that the state is going to be getting. I guess the insurance companies will have to pay some sort of tax already by providing the insurance for the additional premiums. And so what's going to happen with that money? Where's that money going to go? And is it possible to have a portion of that money help fund the exchange without adding an additional user fee? So we were talking very broadly about all of these ideas. Staff was going to go back, and I think, as John said earlier, going to talk with some of the other departments about some of our options. There was also some great ideas about advertising, maybe on the website, how that could work, who would we let advertise, how we would get those fees, what that might look like. I think that's at least my broad overview of where we kind of ended up, and that topic we talked about briefly at the first meeting, in more detail at the last meeting, And we hope to get more information from staff to have a fuller conversation at the next subcommittee meeting.
For the record, John Hager, just to add a couple of points. First of all, the enrollment figures that you see there are preliminary numbers that were provided by our consultants. We have compared them to those that that are provided by the Department of Health and Human Services, and they're pretty close. There's a few exceptions to it. We've decided that it would be better if we use those numbers by the Department of Health and Human Services, and I expect to get those sometime either today or tomorrow, or possibly early next week. The advantage to using the Department of Health and Human Services numbers is that they will be able to up those on a monthly basis. I think it's important going forward through the budgetary process that our numbers are in lockstep with those of DHHS, and so these numbers will change a little bit. And so because of that, you would see a change in the PM fees that you see here. But I just kind of wanted to, again, give you an idea of how the numbers change over time, starting in the first year and going up pretty drastically, and then leveling off toward 2017, 2018, if we do it this way. You'll notice that on page 7, that's with ACA funding for all of maintenance and operating in 2014. The amount that we need in fiscal year 2014 would only be about 52 cents per member per month. We would charge $6 per member per month and gradually go up over the years till we got to, it would be $7.55 in 2018. And again, these numbers will change. But that would help us build up an operating reserve. And in 2016, you actually see we'd actually lose money. We'd be designed to lose money to get our reserve into about a 30 to 40 day operating reserve. So that was one method. Now, the second section there, you see the higher enrollment figures. That was based on the entire small group and individual market. You can see that the difference in the cost, it's about half. Originally, it's about half. The first several years, and then it almost becomes about the same in 2017. It starts to merge as we expect to get more enrollment on the exchange, and there's a couple of things for there. Number one, the definition of a small group changes, where we add those employers with 51 to 100 people, and so that changes it. So you see that the small bump up in the enrollments in the exchange. As far as the total enrollment, we're starting to gather more market share is basically what it comes down to. So those ones start to merge. If you look on page 8, it's the funding without the maintenance and operating funding from the Affordable Care Act in 2014. You can see the significant difference. It goes up from the 52 cents up to $10.12 in fiscal year 14. Fiscal year 15 goes up from $4.70 up to $9.23. So in order to build a reserve up, we actually end up starting quite a bit lower. We charge a little bit more, so it's all the way up to $11 per member per month based on again. These numbers could change pretty drastically when we get the actual numbers, the actual costs of the BOSS RFP and the eligibility engine RFP. So that's something to keep in mind. But again, you see the slightly higher dollar amount required on the total small group and individual market, and those going forward. So this is just kind of an idea just to kind of get you thinking about where we're headed, the possibilities. And again, we need to go talk to the policymakers and decide whether or not other funding sources are available.
John, I have one question just to make sure that we've got this accurately clarified. When you say with and without ACA, you're not talking about the mandate. You're talking about operations and maintenance funding. Is that correct?
That's correct. That is the maintenance and operating costs, approximately $12.6 million in fiscal year 2014 would not be available on the items in page 8. Now, this changes drastically if the mandate goes away. There's a couple of things. If the entire act is overturned, all the implementation funding goes away, and we really have to go back to square one when we get to stuff. If they just eliminate the mandate, we may still get the funding for the implementation, but I would expect our enrollment to be a lot lower than what you see here, and the PM cost would be a lot higher, and we really need to start talking about some other kinds of funding sources. You do see the other funding sources that we think that we can charge just within our authority. If we add a dental plan or a vision plan, you've gone on the exchange website, you've chosen your health plan. Hey, what about a dental plan? What about a vision plan? These are parts to your health that you should consider. Obviously, for pediatrics, it'll be required, but for adults, it's not required. You add this on, and you could charge some kind of fee to those plans. We don't know exactly what those plans would be. We've estimated them to be pretty low, but again, the premiums for those plans are a lot lower than the qualified health plans. So far, I think we're the only state that's considered Medicare referral fees. Your neighbor just came over and said, hey, I just got on the exchange and I got insurance, and you say, oh, I'd like to go on there too, and you put in your information, and you say, I'm 67 years old, and it says, oh, sorry, too bad, you're out of luck, go somewhere else. So I think it makes sense that you put in your information. We may not be able to provide you the coverage, but we can redirect you to a Medicare exchange. There are profitable Medicare exchanges out there. We should be able to get a referral fee to push them over to their exchange, and so we'll have to consider that. And then obviously the advertising revenues, and that one I think we have to, I actually haven't yet, but I need to talk with our Deputy Attorney General to determine whether or not we can advertise on a state system. That's it.
Can I ask it? Ron Klein, can I ask a question, please?
Sure.
John, if I understood before, previously this meeting, you said that the premium has to be the same inside the exchange and outside the exchange. So if you assess a PM fee on exchange people only, then it will be financially disadvantageous for anybody who wasn't subsidized to buy their insurance through the exchange. Is that correct?
Yes, sort of. So it's
definitely.
Well, yes, it's a matter of qualified health plan versus non-qualified health plan. So a qualified health plan has to be the same benefit, same premium inside and outside the exchange. So if you enroll in the exchange and there's an assessment on enrollment in the exchange, that enrollment assessment is charged as the administrative expense by the carrier and distributed to all enrollees of the entire qualified health plan, both inside and outside the exchange. So while you are outside the exchange, if for some reason you decided to join that coverage outside the exchange, and the way you would see that is an insurance carrier would want to try and get you to not go on the exchange, because unless there's a premium tax credit, there's no reason to go there. The carrier says, hey, come on my exchange because I'm not going to have to pay a fee for you. The cost would be the same as for the participant. The premium would be the same because it's required to be the same. The difference lies in an insurer could say, okay, well, this is the qualified health plan, and this is my product that is a non-qualified health plan, and we just happen to make this one $10 lower because there's no fee for the exchange. So even though it's the same plan, it's a non-qualified health plan, outside the exchange, a person will probably go to that plan instead. I don't know if the carriers are going to do that and try and license two different plans, but that's certainly a possibility. So the adverse selection issue comes in in place where a person will have the decision to go on a qualified health plan or a non-qualified health plan on the outside of the exchange. So that is certainly an issue. Because of that, it may make sense to require a fee based on the entire individual small group market. Then again, there are other services that are impacted. The providers, there's a lot of different impacts to the entire market at the provider level, insurance level, and so we need to again talk with the policymakers and determine what our boundaries are before we go forward with a thoughtful, considered motion by the board.
But so for instance, an insurer could have a QHP in and outside the exchange that had the exact same premium, but then make a minute change to that QHP, say it's not a QHP, and then get away from the fee. So I mean, there are sort of ways around that.
Correct.
You wrote in the report, and I'm just sort of coming back to what you said before, and my idea here, just sort of trying to spread the cost over as large a population as possible to minimize the PM. In this report, you said that even going to the whole small group and individual market, you thought would require legislation. So if you were going to go and seek that legislation to try to expand this to small group and individual market outside the exchange, with that same effort, you could try to encompass the entire large group market as well, and then again lower the PMPM fee, because either one, if I'm understanding correctly, is going to require legislation. Now, you know, the politicians can tell us which is more likely to pass, but in either case, you're going to require statutory change, if I understand correctly.
Yes, sir.
Madam Chair, if I'm following the conversation right, I think one thing that's sort of left out of the discussion is, you know, the $10 PMPM on a qualified health plan inside and outside the exchange. You have to remember that you only get the federal subsidy inside the exchange. So why wouldn't people want to pay a $20 fee if they get a $400 credit?
You know, my point was, I'm sorry, I was going to say my point was, it's going to be an adverse selection for anybody who doesn't get a subsidy. So if yeah, I agree with you clearly. If you have a subsidy, then it's worth paying $10 a month to get a $80 a month subsidy. But if we're trying to recruit non-subsidized individuals into the exchange, then there would be adverse selection with a fee, I think.
Madam Chair, this is Leslie Johnstone. I should have made this comment when we were talking about the budget side of things, but I would be curious in future presentations if there would be a way to separate the fixed cost from the variable cost. I'm not clear yet how sensitive the total cost is to the enrollment volume, and if we have that kind of separation on the expense side, that may help me anyway in understanding how sensitive that budget is to the enrollment figure.
Great comment, thank you.
For the record, John Hager, I think once we get the information from the vendors, the eligibility engine and the BOSS vendors, I think it will we'll provide that at that point, because those will be accurate variable costs. I can't say that these are accurate yet, so.
So Ms. Atkins, at this point, you do not make a recommendation that we adopt anything in here. This is just your starting point for discussion for further subcommittee meetings. Is that correct?
Yes, that's correct. Yes.
All right, thank you. Well, thank you very much. You guys look like you haven't been doing much over the last month. All right, the next report on the agenda is the Plan and Certification and Management Subcommittee, and I'm chairing that, and I want to just give a brief overview on this. A lot of our work is still contingent upon getting some of the rules from the federal government. But the Plan, Certification, and Management Advisory Committee is charged with providing the following: selection of a benchmark plan and essential health benefit package, the certification criteria and rate review processes for the qualified health plans, selection of the qualified health plans to be offered on the exchange, and standardizations of the health plans. We had a meeting where we had kind of a strategic mini plan put together, and I will highlight those, and it is our recommendation that these be adopted. The first key principle is to encourage participation. The second is to minimize adverse impacts on the exchange market and state-sponsored healthcare programs. The third is to minimize unintended market disruptions. Fourth is to protect special populations. The fifth is to monitor, evaluate, and report routinely. The sixth is to create a market facilitator. And the seventh is one that we've got some changes to, where we asked John to help us come up with some language, and I will read that one. Number 7 is to maximize continuity of care. You will hear in a lot of our discussions the term used, churn. This is directly related to that.
As individuals move between the exchange and state-sponsored healthcare programs, enrollees could experience a change in the availability of providers, a loss of pre-authorization for a procedure, and other discontinuities in their care. The exchange should be designed in a manner that minimizes disruption of care. And the 8th is to improve patient outcomes. The certification standards for qualified health plans should be set in a manner that encourages or requires carriers to set measures that will improve the health of enrollees. So it would be our recommendation that the board approve these key principles that have been discussed and recommended by the Plan and Certification Committee. If you have any questions, I'd be glad to try and answer them.
I have one question. This is Lynn Atkins. I guess number 7. I would assume that going back and forth between the between programs would not only be a disruption in care, but could also be significantly expensive if if the premiums have to start over again every month. Not the premiums, the deductions. Deductibles, I'm sorry, the deductibles. The annual deductible, if that would, so I'm not sure where that would fit in here, because it just says prevent disruptions in care. I don't know.
And I'm not sure that there's anything that we as a board can do about the deductible side of it. And you're absolutely correct. I think Dr. Klein has brought this issue to us several times. And Dr. Klein is the vice chair of this committee as well. So you may want to add some comments to this, because I know you're very sensitive to this issue.
Thank you, Madam Chair. Yeah, I think the discussion was that we would try to minimize the churn as much as possible because it would be disruptive. And if I remember Mr. Dewar, he said that, maybe Mr. Wilton can help here, is that they need to assess Medicaid eligibility twice a year. So that means that once a decision was made, you would be on that plan for at least 6 months. And they said you can't do any longer periods than that. And I guess then one way to address the deductibles would be to make them 6-month deductibles. So if your deductible is $500 a year, make it $250 per 6 months as a way of addressing that. But yeah, I will spare the board the actual details of churn, but as a physician trying to care for patients, it's very disruptive to try to care for patients.
I would like to add something.
Please.
This is Dr. Ford. I also like to remind members of the subcommittee that not all doctors take all insurances, and there's nothing in the Affordable Care legislation that says a doctor must take any health insurance. So there are many doctors who do not take Medicaid patients, but they take other qualified health plans. So if a patient was transitioning back and forth from Medicaid to a qualified health plan, they very well might lose their doctor. So I just wanted to point that out.
Thank you, Dr. Ford.
Are we taking public comment on this section now, or are we not?
We do, and we have someone here in Carson City that would like to make a comment. I'm not sure if you have the microphone turned on.
Yes, mic's on.
Okay, thank you.
For the record, Elise Moss-Bedecker with AMD Healthcare Consulting. My comment is on number 7 and also number 8. Number 7 with the maximized continuity of care. I think that is a very good thing that the committee included in this report. I would just like to add that the HITECH Act, which relates to health information technology, would be a great asset to address this with the electronic health records. And
the flow of information with that, with interoperability, so just wanted to throw that out. And item number 8, improve patient outcomes. I just want to get on the record that with the Office of the National Council under Health and Human Services, that there are a lot of best practices out there for that. And again, back to the interoperability of health information technology would be a way to help to address that between carriers, because I know that here we are addressing the exchange, but there are many components of the Affordable Care Act other than just the exchange that are dealing with these very same things. And so as we tie them in, and I know we have Health Insight for Nevada that could help address both 7 and 8, items 7 and 8 with our exchange. Thank you.
Thank you. Is there comment in Las Vegas?
Dwight Mazzoni for the record. A point of clarification on Dr. Klein's comments. Are we talking about someone moving within the exchange from Plan B to Plan C, or someone coming in?
Medicaid, back and forth in Medicaid and then private. So as so as an example, somebody has Medicaid. So as an example, somebody has Medicaid, gets a job, they no longer qualify for Medicaid. Now they're provided health insurance, or vice versa. They qualified for a plan in the health insurance exchange. They lost their job. Now they qualify for Medicaid. So that moving back and forth, and especially in Southern Nevada, with a lot of hourly workers. I mean, I routinely have patients in our practice who are hourly workers in hotels, and you have to have a certain number of hours to qualify for health insurance. And if they cut back, then 1 month they may not have insurance, and the next month they do, and it goes back and forth every month. And in terms of just the administrative burden of trying to provide care under that circumstance, it's very difficult. So moving back and forth, yeah.
All right, I appreciate the comments. Do we have a motion to approve the
One more comment, Madam Chair.
Okay.
Sorry, one more comment, Leanne Gasway with AHEC. One thing to keep in mind about the deductible issue as we move forward is Society has just released an additional bulletin on actuarial value determination and cost sharing subsidies. So not only do people under 40% of federal poverty eligible for a premium subsidy through an advanceable tax credit, but they're also eligible for a cost sharing subsidy. And so we've just now received, just a month ago, just 40 days ago, I believe, received a bulletin of the regulatory approach that they plan on taking to administer the cost sharing subsidies. And what that will effectively do for those products is eliminate or greatly reduce the deductibles and cost sharing for those lower income strata. So that person wouldn't necessarily go from a Medicaid no copay to a $500 deductible plan. They would go to maybe a $100 deductible plan, because they're going to get that cost sharing subsidy, which has a much higher actuarial value because they qualify for that due to their lower income status.
Madam Chair.
Thank you.
Yes, please. So a couple of points of clarifications. I believe that cost sharing threshold starts at 200% of federal poverty level. It doesn't go all the way up to 400%, but it does certainly at 250% of the federal poverty level. But that definitely does ease some of the burden as far as deductibles go. Remember that this is just a strategic plan. These are key principles in how we're going to have the committee make its recommendations going forward. So a lot of these decisions, these items for discussion will happen in the committee and then will be brought back to the full board. This is just to provide a broad framework for how the committee makes its decisions. I will say that we are working with DHHS and Medicaid, with Administrator Duart's and Director Wilden's offices, to make sure that we have some continuity between Medicaid and the exchange, and how that works exactly. We still have to work that out, and we'll bring that to the committee as we get to it. The biggest concern that I have coming from my previous job is the continuity of care, the issues on pre-authorizations, the changes to providers. if you are on Medicaid and you go to the exchange, if we can have the Medicaid vendors provide an exchange product, then you can continue with that product, and all of those items should follow you. We could require that the vendor has pre-authorizations that remain in place. They will maintain their network because it's the same vendor. So those issues are set. The issues as far as deductibles and coinsurance, I don't think we can do a lot about that, although there is the cost sharing provisions that could help ease that a bit. But again, these are just broad items to kind of direct the committees in their decision-making process.
John, if I can just clarify, and I think Dr. Ford made the same point previously. You can have a vendor provide a Medicaid product and a commercial insurance product. Doesn't mean the network is the same in both, unless you want to try to legislatively mandate that. So that's not necessarily true. I mean, you can participate in some plans from an insurance company and not in others. So I think that's not necessarily the case in terms of that. The pre-authorization hopefully would be uniform though.
Well, and again, I want to bring back to the point that John's making too, that these are our high-level key principles, and we'll get down into the weeds on this as we move forward. And all of your comments are all really good ones, so I appreciate it. I would like to go back to seeing if the board is willing to approve these key principles.
So moved, Madam Chair.
Second, Lynn, okay.
Is that you, Lynn?
Yes.
Okay, thank you. I have a motion and a second to approve the key principles for the Plan and Certification Committee. All those in favor?
Aye.
Any opposed? Thank you very much. The second recommendation out of the committee is for the Division of Insurance to conduct the rate review. The Affordable Care Act requires qualified health plans to be reviewed and approved. And since the Division of Insurance already takes care of certifying health actuaries and doing the rate reviews, it is the recommendation of the committee that the Division of Insurance do this for the health insurance exchange as well. Do we have any questions or comments? Or Mr. Kipper, would you like to say anything?
Madam Chair, for the record, Scott Kipper, Insurance Commissioner for the great state of Nevada. And we currently perform this function. We use grant funds that we've received in our ACA grant to perform this important function. We anticipate that as long as those grant funds are available, we will be able to continue to do this without any problem at all.
Thank you, Mr. Kipper. Does anyone have any questions for him? There being none, is there a motion to approve this recommendation?
So moved, Lynn Atkins.
Second, Marie Kerr.
We have a motion and a second to approve the second recommendation that the Division of Insurance conduct the rate review for the insurance exchange. All those in favor?
Aye.
Those opposed? Lynn Atkins made the motion and Marie Kerr seconded. All right, motion passes. Thank you very much.
And the chair of the Consumer Assistance Committee is Ms. Atkins.
Okay, so it looks like we're on page 11. Our first recommendation is about a general outreach strategy. To ensure maximum return on marketing and advertising investment, it's necessary to have a cohesive outreach strategy. The strategy on the following pages is a starting point to be refined by the communications officer and the marketing and advertising vendor of the exchange. This outline does not specifically include the role of navigators and brokers, as their roles have yet to be determined, though their roles may fit within items 3 and 4. So the strategy involves assembling a team with expertise, capacity, and experience in conducting successful advertising campaigns, which would include hiring a communications officer, hiring a marketing and advertising
vendor. The marketing and advertising vendor will be responsible for branding of the exchange and message development, design of a multifaceted, compelling advertising and marketing campaign, outreach to ethnic and tribal communities, utilization of avenues for free media, development of collateral material, media buying strategies, and development of ongoing corporate and civic partnerships. Also conduct market research to shape strategies and messages. Partner with private and public sponsors to increase market penetration with the goal of increasing health insurance enrollment. These entities may or may not be navigators. Again, reminding everyone that the decision on navigators and brokers has not been, there's no recommendation, we're still just discussing that. Within that, search for private sector partners willing to provide pro bono in-kind services to promote the exchange, partner with key commercial businesses to provide advertising in high traffic locations, partner with nonprofit organizations to reach segments of the populations that are not otherwise engaged, and partnering with state entities. So the goal is to get ourselves out as many possible places to get the word out for folks to sign up for insurance through the exchange. Collaborate with business, industry, and consumer groups to maintain broad support for health reform and support successful implementation of the Affordable Care Act. And measure and report success. So those are our, that's our general outreach strategy. John, do you have anything you want to add?
For the record, John Hager, just two quick items. Notice that after the recommendations of the committee, we added the language "and tribal" for the advertising. The marketing and advertising vendor needs to make sure they include ensuring good outreach in the tribal communities. And one possible champion in item number 4, collaboration with the business or industry. We could view insurance carriers maybe champions. In Massachusetts, a couple of carriers got together and put forward some funding for a advertising campaign that complemented the exchange campaign, talking about why you should buy insurance. Why it's necessary to purchase insurance. So that's a possibility. Don't know if we'll have any takers on it, but we will certainly do our best to get as much participation in this process as possible.
Do any of the members have questions for Lynn on her outreach recommendations?
No questions in Vegas.
Doesn't look like we have any here either. So do we have a motion to accept those recommendations?
Dr. Ford, I so move.
I'll second. This is Leslie Johnston.
All right, we have a motion and a second to accept that outreach strategy. All those in favor?
Aye.
Any opposed? Motion carries. Thank you. Lynn?
Recommendation number 2 is the types of consumer services for enrollment. So this conversation was obviously centered around helping access points and helping folks sign up for healthcare through the exchange. So the first and premier way is we're obviously going to try and drive most traffic through the website. That's the cornerstone of the exchange access. We also believe that we should have a toll-free number, and that was part of the RFP from the business operations solution vendor, is our understanding. So there will be a call center if people are having problems on the website to access it or can enroll through the 800 number. A toll-free number for the hearing impaired. We actually all did not like the idea, I think most of us, at least we did not like the idea of doing this by mail, but apparently there's been some more research and we have to provide that, so that is why that has been added. And then also walk-in centers. We definitely wanted places where people could go to sign up, so they didn't have to do it from their home or a library or their business, that they actually could go someplace without actually having freestanding bricks and mortar places that we are running, that we would use resources and centers and nonprofits and government agencies that are already have bricks and mortars locations that we could actually put someone or put a kiosk in so people could sign up. So that is the walk-in center section, and then so those are the things that we are putting forth to the committee, to the board for approval. And then we also were discussing, but we don't have cost analysis on this, but kiosks, which were brought up earlier, and again, yes, grocery stores was just one thing thrown out. I don't think anyone is thinking that we're going to be plastering the kiosks through the grocery stores, but maybe there's one or two in some of the communities that maybe don't have other areas where folks are going. So we're trying to think as broadly as possible. We'll also want email and website chat support could be provided by the business operations solutions vendor. There was someone brought up a mobile phone app, because we want to be on the front end of the technology, understanding that who knows if that could happen, but we would love for that to be able to happen. And then we also discussed the idea of kind of taking the registration process mobile, which doesn't mean a mobile phone, but having some sort of van or whatever it is that we actually can go to more remote places to help people sign up, to help people register. So.
Does anyone have questions for Lynn on the second recommendation?
This is Leslie Johnstone, Madam Chair. This probably is getting down into the weeds a little bit, and I don't even know if it's applicable these days, but fax and emailing the forms to a central location as well. That might be included under mail, different types of mail sent.
John, I don't remember us talking about fax.
I don't think we talked about fax, although I would have considered that part of the paper application process, which we didn't want to do. A fax is pretty inefficient. We don't have to do a fax, and it appears that we don't, that mail is required, but fax is not. Hopefully they have email access. They can call the call center to enroll. So there's other methods besides faxing. The biggest issue with any kind of paper application is making sure that you transcribe that information into the system properly and you don't have errors. Ms. Johnstone can recall from working at PEB all the errors that we had to encounter with paper applications. If we can minimize that in any way, that would be helpful. So we are going to provide the mail service because we're required to, but we are going to try to promote the web services call center as much as possible.
And this is Lynn, and I'm sorry, and this is Lynn, and I guess also that's part of when we're going to have the navigator discussion, but any of these walk-in centers, it would definitely be promoted to people that if they do not know how to use a computer, don't have access to a computer, they could come to a walk-in center and somebody there would help them with the online registration.
This is Leslie Johnstone. I would just offer a suggestion to not underestimate the number of people that don't have access to web and that don't have access to transportation to get to a walk-in center. We're trying to get to a population that's not easily accessible, so even though it's not convenient for us, I think we're going to have to take some of the more traditional approaches as well.
Madam Chair?
Yes.
I just would want to caution everybody. I wouldn't underestimate the power of the web. I commented earlier that we have Welfare's got the Access Nevada going. That's a web-based application. We just passed through the 25% of applications being taken through the web. So everybody says that population will always be walk-ins. Well, I think we're showing that different. 25% of applications now taken web-based. So and growing. It's grown from about 9% 4 or 5 months ago to 25% now coming in through the web.
Well, and I will also say that, that fax could fall under that toll-free number area.
We have a question, a public comment in the South.
Yeah, for the record, Barry Gold, AARP Nevada. I wouldn't discount the use of faxes because I think there may be some navigators that are out in the community that are assisting, that serving with underserved populations that do not have electronic capabilities, and that's what they may do. I don't know if any of the low-income energy assistance programs, some of those people that help them may fax those information in, and if they're the ones that are being navigators, they're going to need to rely on the technology that they currently have.
Thank you.
Thank you.
I have a quick question. This is Dr. Ford. Is the website going to be bilingual or just English?
We have required that the website be both in English and in Spanish. As far as other languages, we indicated that a requirement must be within those requirements of the Affordable Care Act. There are requirements about other languages, but it's kind of vague actually on the thresholds for the population. So, if you have somebody that speaks Thai in Vegas, we do all this work for one person, or if they speak Mandarin, I don't know what the possible languages are out there, and we probably need to do some analysis to see what portions of a population don't speak English or Spanish and consider that. But there's going to have to be some cost-benefit analysis on, at some point, it's cost prohibitive to provide services. On the other hand, the Affordable Care Act pretty much says you have to provide it for all languages, so we'll have to figure out how that's supposed to work. And yeah, we'll do that in the marketing research, absolutely. And we will also engage our federal partners to determine what the thresholds should be.
All right, do we have any other discussion on recommendation number 2? All right, do we have a motion to accept these recommendations?
Move to accept. This is Marie Kerr.
We have a second?
I'll second. This is Leslie Johnson.
Thank you. All those in favor of adopting recommendation number 2?
Aye.
Aye.
Any opposed? Motion carries. Thank you.
And Ms. Kerr is the chair of the Shop Exchange Committee.
The Shop Exchange Advisory Committee has been charged with setting up a health insurance marketplace for small employers, and we've been tasked with providing recommendations regarding a number of points. First, the number of QHP issuers and number of health plans available at each of the 4 plan levels. Next, the extent to which plan benefits may be standardized, i.e. point of service cost sharing. Plan designs and SHOP compared to the individual exchange. The employer purchasing model and flexibility in offering employee choice. Next, mitigating risk selection across plans and plan levels. And finally, minimum contribution and participation requirements. To assist in the development of these recommendations, we started with 3 key principles, and we added a couple in our subcommittee process. The first key principles we had were encourage participation, 1, and I'm not going to read through all the subheadings, the sub-issues in this. Number 2 was minimize adverse market impacts, and we also started with monitor, evaluate, and report routinely. During the subcommittee process, it occurred to us that there were a couple of extra things that should be added, and the first one we came up with was minimize unintended market disruptions. We recognize that the ACA would disrupt the current market. However, we don't want to have any unintended market disruptions. Next, and very much similar to the individual exchange, we want to maximize continuity of care as you have people transitioning between various, the individual market and the shop. We want to make sure that there is continuity.
Do any of the members have questions for Ms. Kerr and the recommendations out of the SHOP committee? Do you have any public comment?
Madam Chair.
Yes, Mr. Hager.
For the record, John Hager, the continuity of care option, we recognize that people that are in the individual market might have a certain health plan, and they go to an employer and suddenly they have a new health plan. That happens today, and there aren't a whole lot of things that we can do about. You're in one health plan and suddenly you're in the next one. You've got pre-auths to deal with. You've got new providers. So we recognize that this might be a difficult subject, but we might be able to provide some impetus to help change the market. We might be able to get the carriers to work better together. Because we are the central location for enrollment, there may be a way that we can include information on the enrollment files that help continuity of care. So we're looking at various options. We recognize that that part of it will be very difficult. Again, in the current market, you're on a plan, you go to a new employer, you've got a completely different plan, you have to adjust. So we'll do it with what we can, but we think we should keep it in the back of our minds.
Is there any public comment in Las Vegas? Here in Carson City? Do we have a motion then to approve the recommendations?
Madam Chair, if we have a quick question first. This is Leslie Johnstone. Is there anything unique in the shop exchange in terms of how we do the outreach and communication? Or was the shop included in the discussion by the, I'm looking for the name of the Consumer Services, if that committee also considered how to best educate and communicate with the shop exchanges?
Leslie, that hasn't been a discussion point. We've been looking at the key principles at this point. Noted that we have a good amount of participation in our subcommittee from insurers and brokers, and I think that in terms of the shop, that is probably going to be your primary point of accessing the public, the employers, employees, is through brokers and other participants, current participants in the market.
Do we have any other questions? There being none, would someone like to make a motion to approve?
Also move, Madam Chair, this is Leslie Johnstone.
Second.
I have a motion and a second to approve the recommendations coming from the shop subcommittee. All those in favor?
Aye.
Any opposed? Motion carries. Thank you.
And Ms. Johnstone is the chair of the Reinsurance and Risk Adjustment Committee.
This committee dealt with is responsible for dealing with two different areas and programs. One is their reinsurance that functions much like stop-loss insurance, and it is a temporary program. And so frankly, we have focused our attention on the risk adjustment program, which is a permanent program. To date, that's where we have focused our attention. And on risk adjustment, after discussion from the carriers that were on the advisory committee, and the advisory committee is largely made up of actuaries and financial folks from the major carriers, the thinking was that we need to spend some time evaluating the risk adjustment criteria that is used under the Medicare program, with the idea that the federal option for having or adopting the federal program may very well be close to what is currently in place for the Medicare program, and that we should spend our time initially looking at what Nevada market likes and would like to make different from the Medicare risk adjustment program, so that when the federal risk adjustment program is released apparently in mid-October, we would be in a position of knowing or having evaluated what we like and don't like about that program, and then being able to have, in the meantime, also developed an alternative approach that if we were not satisfied with the federal program, we would be able to pursue a state risk adjustment program. Unfortunately, the timing for that's pretty tight because the state alternative would need to be submitted within 30 days after receiving the federal option. So we need to kind of work on parallel tracks, but initially we will, I think, try to use the resources that are on the advisory committee, actuaries that have experience with the Medicare risk adjustment program to help us evaluate that approach so that we're in a better position of talking further on whether or not we feel strongly to have a state alternative fully developed, or if we're more inclined to look at the federal approach. So with that, and that's kind of the capacity of me being able to describe risk adjustment, I would open it up to any questions, and we've got help from DOI here if I misspoke on anything.
Do we have any questions? No, I might ask a question of Scott Kipper. I don't remember if it was this morning or this afternoon or during the legislative this morning. And I think I'm sure it was Teresa that was saying, one of the participants was saying that very few of the states are trying to do this analysis themselves, because at the end of the day, everybody's going to rely on the federal government. Can you discuss that just a little bit more?
Certainly, Madam Chair. For the record, Scott Kipper, Insurance Division. And that's exactly what Ms. Miller said this morning when we were discussing this risk adjustment program, that almost all of the states, it appears, at least at this point, are leaning towards utilizing the federal government to implement the risk adjustment program. It is my understanding those regulations won't be ready until October or September, and we have to make a decision shortly thereafter in which direction we're going to go in order to have enough time to implement the program. But what Ms. Miller did say is that it appears that most states are leaning towards using the federal government. I think that accurately captured her sentiment.
If I could just add that part of our discussion was we wanted to end up with a risk adjustment program that the carriers were comfortable with and bought into the process and where the data was coming from. And so in the last meeting, looking at something that they were familiar with from the federal Medicare program seemed to be a real linchpin in how they would like to approach this.
Do we have any other questions or comments? John?
For the record, John Hager. So while the committee has made the recommendation to conduct an analysis to determine the Nevada-specific factors that should be used in the risk adjustment model, that's something that I think that staff has the authority to do, and we've already started that process. We've already asked one of the actuaries on the committee their opinion, and the Division of Insurance is working on it as well, so we're kind of working together on that. So the recommendation is there. There's no action that's specifically required, but we wanted to make sure that the board was fully updated on what the committee is doing.
And I'm not trying to object to any of it. I just wanted everyone to know what statements were made this morning, because I was kind of surprised with that. All right. If there are no other questions, do we have a motion to approve the recommendation from the Reinsurance and Risk Subcommittee?
Marie Kerr, motion to approve.
Okay, may I have a second?
Second, Lynn Atkins.
Thank you. All those in favor of the motion?
Aye. Aye.
Any opposed? Motion carries. Thank you very much. All
right, the subcommittees are done. I'm actually shocked how much work has been done by the committees and all the members of it within the last month. And I want to thank all the chairman and vice chairman and all the committee members that have worked so diligently. And of course, John and his staff for putting all of this together. So congratulations for a lot of work done in a very short period of time.
We will not do 10 committee meetings in 1 month again.
All right. John, we have, no, I guess this is Shauna again. Sorry. Discussion and possible action for the alterations to the staffing plan that we presented at the last board meeting. Would you like to bring us up to speed on that, please?
I would, thank you. For the record, Shauna DeRuse. At the last board meeting, we presented and the board approved a staffing plan that added 4 positions in May, 3 positions in July of this year, and then 2 more positions in July of 2013. The board approved the recommendations and gave the executive officer the authority to review and increase the salary of one of the positions, the quality assurance specialist. They felt it should be more robust in duties and responsibilities, and therefore the salary would be commensurate with those increased duties and responsibilities. While the staff was preparing those changes to the quality assurance specialist, we also noted that salaries of 2 other positions, the finance and research officer and the communications officer, appeared to be out of sync excuse me, with other similar positions within the state service. Positions, as they were put together, were compared with current descriptions of classified employees in state service, and references were made to grades and steps within the classified service. Also, the previous board reports showed the salaries for the positions with the furlough deduction in those salaries. The attachments that are included today do not include those furlough deductions and show slightly higher than what you saw in the previous version. The report does. The report shows that the salaries include the furloughs, the attachments do not. So I'm sorry for any confusion that caused. So just to talk a little bit about grades and steps. In classified state service, a grade is a term that generally describes a level of responsibility of a position based on the complexity of the job requirements, potential financial consequences, and how many positions are supervised. A step is generally based on an individual's time in the grade. Currently, steps have been frozen due to the state of the economy. Normally, a step of position would each year on their anniversary date, thank you, on their anniversary date, they would increase a step, thinking that in that last year they've gained in skills and knowledge about that position, and therefore they would progress up to the highest step within the state, which is currently a step 10. So each grade has a set salary range. The salary for the individual at a step 1 is approximately 70% of the salary at a step 10 in that same grade. Most people enter at a step 1 when they start at a position. Your steps do go with you. You may start at a 35.5, and then if you go to a new position and you're suddenly at 37, your 5 goes with you. You don't lose that in the state. So to ensure that salaries are in sync with other positions in the state service, we've tried to compare the duties and responsibilities that our unclassified positions are currently being proposed as with other current classified positions that are there. So the quality assurance specialist, which the board asked us to look at and review and kind of create more robust duties, we looked at a quality assurance specialist originally that would have been a grade 35 at step 10. We reviewed that and then looked at a quality assurance specialist 4 position in the classified state service, which is a grade 39. So the quality assurance specialist 4 creates plans to monitor quality for individual medical cases, and
And the exchange quality assurance specialist would be focused on creating plans to monitor insurance organizations' ability to meet the quality standards that are focused on medical, instead of focusing on medical cases individually. This position would be implementing the exchange's quality control processes, and the description is in attachment B. Based upon that analysis, we increased the salary for that position to $76,787, which is equivalent to a grade 39 step 10. The finance and research officer, then, we originally had set at a grade 37 step 10, which would have been equivalent to an administrative services officer 1 in classified state service. Looking at the requirements of the position, the duties and responsibilities seem to be in alignment with either an ASO 2 or an ASO 3, right in that area. The positions will ultimately oversee all 4 positions on our staffing plan and would be responsible for the business functions of the exchange, including financial reporting, budgeting, forecasting, rate setting, grants, quality assurance, including supervising that quality assurance position, and also request for proposals, contracts, and leases, and that position description is attached. So since this position supervises the quality assurance specialist, we felt, and with those increased duties also there, we felt that this one would be better suited to be at a 40 step 10, which would then be 1 grade higher than the quality assurance specialist who they would supervise. It was determined, we looked at moving the quality assurance specialist out from under this, so that may not be a factor, but we felt that it should stay under the finance and research section because of the role of the quality assurance specialist is really a business function. It'll be looking at contracts and qualified health plans and part of the benefit functions there. So that was, we felt was a good place for that to be. So based on that analysis, we request that the annual salary of the finance and research officer be set at $80,423, which is equivalent to the 40 step 10. The communications officer position was originally also proposed at a grade 37 step 10. For comparison purposes, a public information officer position 2 in state service, classified state service, is a grade 37. Upon further review of the requirements of the position, the duties and responsibilities seem to be in alignment with the position that is currently over at the Nevada Department of Transportation. They have a director of communications position, which is a grade 40. One of the duties of the exchange communications officer is to be the PIO, but it goes much further than that. They will be directly directing the marketing and advertising campaign. They will work on that RFP to go through and select a vendor for that campaign. They will do training in the marketplace. They will do outreach. They will travel and work with the tribes. So this is a significantly more robust position than a PIO. So based on that analysis, the staff requests that the annual salary of the communications officer also be set at $80,423, that grade 40 step 10. So the recommendation of the staff is to increase the quality assurance specialist to $76,787, which is equivalent to grade 39 step 10, and the finance and research officer and the communications officer both to $80,423, which is based on a grade 40 step 10.
For the record, John Hager, I would like to point out that that these the staffing plan with these changes have already been submitted to the budget office and the interim finance committee, with the assumption that you would approve it. And if you don't approve it, we can always decrease there. That's easy to do. We sent an email to the board before we sent that out, because we wanted to make sure that the board was aware that we were doing that before it got made public. And we say, well, what the heck, they're going outside of what we requested. So if the board does not approve these changes, we can always decrease what we're asking for at IFC, but to approve.
Thank you. Do we have any questions?
Yes, this is Lynn in Las Vegas, and maybe it was a part of this, and if so, I apologize. Are all of these positions required to be in Carson City?
Yes, that's. Whoa, excuse me. Yes, that's where our staff is located. If you recall, during the discussion about the expenditures for the budget, there was quite a bit of travel between here and Las Vegas. But there's going to be a lot of work that we have to do at the legislature. There's going to be a lot of communication and coordination with other state agencies that are located up here. So yes, we will be requiring all staff to be in Carson City. Additionally, we're only going to have one office location. Adding an additional office location would add additional costs, so that's why we're going to have them all for Carson City. But we expect to do a lot of travel down south.
Any other questions? All right, what is the pleasure of the board?
I would move approval, Madam Chair. This is Leslie Johnson.
Second, this is Marie Kerr.
All right, we have a motion and a second to approve the alterations to the staffing plan and the budget for salaries. All those in favor? Aye. Any opposed? Motion carries. Thank you. All right, John, getting back on schedule now, we're over to item 11, which is the memorandum of understanding between the exchange and HHS and the Division of Insurance.
Madam Chair, for the record, John Hager. So we started to get that finalized at the end of last week, and then we thought, it's probably a good idea if the Division of Insurance and the DHHS have review it before we give it to the board. So we've gotten some input back. We are going to coordinate that, and we'll get that to the next board meeting. It is a very broad document, a general document. I think the three entities all agree that we've been working very well together, and that we'd like to continue in that format, in the way that we have been continuing. So you will see the document show basically who is going to be a party to the various discussions and who will be lead to them. But we feel that a 5-page or 4-page memorandum of understanding will much better suit Nevada than some of the 120-page memorandums of understanding that other states have. We don't think that we need to create a highly technical document that outlines everything, because we do in fact work together. And if we decide that we're not working well together, then we can obviously change that and start spelling it out in greater detail, probably with the help of the governor's office if we're that into it. But I think we're working out just fine.
All right, well, we'll look forward to seeing that MOU then at the next meeting. And the actual last item that's really a discussion item would be the non-budgetary changes to NRS.
For the record, John Hager. So this year we are required to get non-budgetary BDRs to the budget office by June 1st. So we still have some time. We can wait till the May board meeting to make any final decisions. But we only found 2 items that we really think need to be changed in our statutes, and those are around 2 definitions. I asked those who helped create the bill where they came from, and nobody seems to recall where they came from. And I thought I asked Mr. Wilden, but I don't remember if I got to talk to him about it. But these 2 definitions on medical facility and provider health care are only used in the definition section. So we could strike them from the statute. They're nowhere else in the statute. However, to make a small change like that, to go up to legislative committees to get asked all the questions that they're going to ask about other stuff for a simple change like this, I would hope that the board will let us just add it on to another bill. It's such a minor change. I don't think we need to go to the committees of the legislature for more get beat up more than we have to.
I have quick question, Madam Chair. This is Leslie Johnstone. Wouldn't it be reasonable to expect that by the time we get done with or further into the advisory committees and the action of setting up the exchange, that we will find other things that need to be modified, and therefore it wouldn't hurt to have this as a placeholder bill?
Absolutely, we could have it as a placeholder bill. We could submit it to the budget office with just these 2 changes, and then withdraw it later if there isn't anything significant for it. The other possibility, we will have to go forward with budgetary BDRs for if we decide to do any kind of fees that are outside the scope of just the exchange, and we could include it on there as well. But then you might not have the ability to do the non-budgetary pieces that the advisory committee proposes. So we could include this in a bill draft request and just hold it, and then if nothing else gets added to it later, then we can go ahead and just pull it. If Director Mollenkamp is okay with that methodology. Put you on the spot.
You know, there's a limited number of BDRs that will be submitted, so I'm not sure that a placeholder it'll actually make through the cut, but you can certainly submit it.
I guess the question that I would have would be, I like the idea of the placeholder if it makes the cut. But is there good reason to have a placeholder there, not only for the subcommittee work, but maybe in a reaction to what might happen in June?
Yeah, well, yes, it depends on how far they go, I guess. If they get rid of all funding, pretty much the only way we're going to get funding is a legislative session, most likely, or a special session, excuse me, if the governor would even call it for the exchange. So if that happens, there's going to be all sorts of budgetary impacts that would be required. I think we could consider it part of a budgetary bill, because that would be a pretty significant change to what we need to do.
Well, I certainly wouldn't object to having it there, have it as a placeholder, and hope that one of our non-voting members doesn't kick us out. Does it,
just so you understand, it's not entirely my decision.
I know, I'm giving you a bad time there. At any rate,
Throw some light bills out,
do we need to have a motion on this to? I guess we do, since this would be a BDR. Well, let me open it up for discussion in Las Vegas. Does anyone have any objection to putting forward this BDR?
No.
All right, if there's no objection at either side, may I have a motion to approve Mr. Hager's suggestion then?
I'll so move.
All right, Dr. Klein. All right, so motion's by Dr. Klein, and do we have a second by?
I'll second Lynn Atkins.
Thank you, Lynn. All right, I'll call for the vote. All those in favor of the motion? Aye.
Aye.
Any opposed? Motion carried. Thank you. All right, item number 13. Do we have any suggestions or discussion for future meeting agendas? We keep full agendas, that's for sure.
This is Lynn. If I shot John an email a little bit ago. This location's a little small. We have people sitting on the floor. So I know it's not an agenda item, but if we could possibly get a different location for the Vegas meetings, we would all, I think, appreciate it.
Wherever we met for the very, very first time, I forgot what that location was, but that was a nice room. No, not the convention, it was the construction.
The contractors board?
Not contractors board, the very first meeting.
Cash?
No, not by Cashman.
Oh, on Cheyenne.
Nice room. I can drive anywhere. whatever.
Yeah, thank you for letting us know that. From looking at it here, you don't pick that up at all. And we've got extra room up here. So, at any rate, so we'll make sure that we have enough space at both locations for everyone that wants to participate. Any other discussion for future meetings? All right, then I'm going to open it up for public comment, as this will be the close of the meeting. Do we have any public comment from Las Vegas?
Yes, we do.
Okay.
My name is Ellen Nakamura. I'm just a citizen. I'm with several organizations, but just for me as a concerned person about how the Silver State Exchange is going to be implemented, if it's possible, can you have this broadcast over the internet at all your meetings that you have? Yeah, I mean, but there's some advisory committee meetings that are not webcast. So I was just wondering if that's possible budgetary-wise, if you're able to webcast those.
For the record, John Hager, absolutely. We are doing our best to make sure we're in a location that can be broadcast over the web. Because we had so many meetings this past month, it was difficult to schedule them in locations that had web broadcasting capabilities. It's not a matter of funding so much as a matter of facilities being available to do so. And so we are doing, wherever we can, we are trying to put it in a location that can be broadcast over the web.
And also, just for your information, the closer that we get to the 2013 legislative session, the less likely it will be that we will be able to get those type of facilities. So bear with us if we're not able to do that. Do we have any other public comment?
If you're not able to web broadcast any of these meetings, then if you can give at least the public an idea of when your meetings where they'll be, so that we can at least plan our day or get people to attend. That's just a request.
By state law, we need to notify the public at least 3 business days prior to that meeting. If you know where our website is on the internet, you'll be able to see those postings as they come, as they go up on the website.
Thank you for that information.
Okay, and our website is www.exchange.nv.gov. Do we have any public comment here in Carson City?
Yes, for the record, Elise Mosvedica again with AMD Healthcare Consulting. And my question is also about the public awareness and notification about the meeting. Is the only form of notification on the website?
No, you can be notified by email, and if you would give...
No, I've been on the list before, and I've attended the preliminary meetings, and then I somehow got dropped off, but I got to the bottom of that, but I'm back on. But my question is, other than the notification via the website that comes from the department, or the consumer actively going on the website to look for these meetings, is there any other form of notification that is done to make the public aware?
You know what, I think maybe since this tends to be more of an open meeting law issue, I'm going to have our Attorney General assist us with it, because there are public notifications in the public buildings, but you would have to be there to see them as well. So let me have Mr. Marcher assist us a little bit with this.
Yeah, there's essentially a few ways to get notice. One is on the web, one is if you're on a mailing list, and the other way is they have to post in various locations around the state 3 business days prior to the meeting. So those are the 3 ways that the public gets notice. So that's generally all that's required by the open meeting law.
Okay.
Okay.
All
But
right.
also the email distribution list is another way of getting it.
I'm on the email distribution list, and I've also requested that other people be added to the list as of last week. But when I give presentations and I'm talking about various things that are going on, people will then say, I don't know anything about that, and then I give them the website. So I guess my real question is, for the success of for people to buy into it, to know what's going on, should there be a consideration of maybe, since this is brand new, this is a cultural change for everybody, that maybe there should be a little bit more proactivity in reaching out to the public and stakeholders to alert them about these meetings and what's going on, because most people do not know unless you're just somehow in the profession. And I'm a consumer advocate on healthcare, and that's why I'm raising this question.
If you will look at our old website, the news website, these board meetings are posted a year in advance. It's the second Thursday of every month. So there's predictability with that. On the subcommittees, because we're dealing with a lot of people in the private sector and arranging those schedules, we're getting them out as quickly as we can. But by state law, we only have to notify it 3 days in advance. There isn't any reason, if we've established a meeting date, that we couldn't put it up on the website.
Now, I'm just asking, I myself, I am technology savvy, not a problem. So I'm just concerned about the other people that are not technology savvy, that maybe do not show up at a public facility 3 days before a meeting to know. Those people that fall through the hole, but who want to know, who want to engage, who want to participate, maybe we need to look outside of the box. That's all I'm saying there, because people do want to know. They really do.
For the record, John Hager, absolutely, and we agree. We have this the vendor for the marketing and advertising campaign, and that will focus on getting outreach to the public. We understand that we don't have that outreach yet. We are doing our best to provide that outreach. We actually last year had a lot of stakeholder meetings, I think some 31 stakeholder meetings, and we're trying to get the word out as best we can. We are short-staffed. We're working on increasing our staff so that we can do that, but we definitely recognize that we need to have stakeholder involvement.
Thank you.
We have another question in Las Vegas.
Go ahead.
Hi, my name is Annette Ravenel. I work for Know Your Cares, a nonprofit that basically educates the community about the Affordable Care Act. I actually had a question, but first, talking about what the lady in Carson City was talking about, Twitter and Facebook works great. I think maybe if you have an account and try to get as many people possible to let them know about these particular meetings, that might be a good way to promote. And I mean, we would all retweet, I'm sure, and maybe more people will know about these particular meetings. I was concerned about the staff, the vote that you had in reference to all these great positions that seem to only be in Carson City, and unless I didn't understand that very well, I wanted to know why in Carson City. You mentioned that it would be because of the legislature there, but I don't think we have that many, we only have our legislation every 2 years, so it seems that they would be probably traveling more to Southern Nevada, and of course to everywhere else in Nevada, but Southern Nevada would be particularly a place that the people from outreach, the directors and all these positions seem to have really good paying jobs. Southern Nevada definitely needs it, and I'm thinking also, you said, yeah, the population increase is definitely here, and you mentioned that you didn't have a location. I understand that, but Gotcha has an office. I'm sure maybe you would be able to have a location here in Southern Nevada. That was one. And two, are you thinking about diversity when you're hiring these people? Women, Afro-Caribbean women like me, for instance, or Latinas in particular, or Latinos in general. So that was my concern.
Currently, yes, we are. Currently, our staff is 50% male and 50% female. We only have 4. By the way, they have 2 people. We are considering diversity. in our hiring process, we've considered diversity on, our elected officials have considered diversity in the board itself, in creating the committees and the members of the advisory committee committees. We considered as much as possible not only ethnic diversity, geographic diversity, gender diversity. So we're doing our best to make sure that's the case. As far as staff goes, we are looking at every application and we'll be happy to hire the best qualified applicant.
How about the location? You mentioned Carson City only. And I mean, if the budget's the issue, you're gonna be traveling to Southern Nevada, that's gonna be a cost that you should think about too in reference to the office.
Yes, we have thought about that.
Do we have any other public comment? Any here in Carson City? Mr. Wilden?
I don't know if I'm a member of the public. I just wanted to express my appreciation to John and Shauna. You said it before, the committees and this group has had a task to do some pretty heavy lifting in the last 3 months, and from a guy who's been around a long time, they've done some heavy lifting, and so I just want to extend my appreciation to them.
Thank you, Mr. Wilden. That means a lot coming from you. At any rate, I would, if we don't have any other further public comment, I'm going to adjourn the meeting. I want to thank all of our members for all the hard work that they've done over the last, since November, October when we got started. This last 2 months has been a whirlwind. I've heard John call it a tidal wave. But we've gotten through it, and I think we've got some good work product, and I'm really proud to be part of this committee, and thank all of you for participating in it with all of us. With that, we'll adjourn, and we'll see you a month. When is that? May 10th? The second Thursday of the month. Thank you.
Now when you're going to start.